my orthopedic consultant, Dr. Jafri Hassan and Dr. Margareta, who cannot present at this time. Before I begin, please let me introduce myself. My name is Martinus Chandra. I was born in Malang, September 27, 1994. My current address is in Infantry Education Center in Bandung. My current position as Medical Doctor of Infantry Education Center. I was graduated as Medical Doctor in 2018 and graduated as Second Lieutenant Indonesian Army in 2022. I was licensed as Indonesian Army Military Health in 2023 and also commissioned officer instructor. As you can see here, I'm still a medical doctor and apprentice of my orthopedic consultant, so I'm aware that I'm still so much more to learn from you guys. Please be kind to have some inputs and critics for me. Irreducible dorsal dislocation of the IP joint of the grade 2 is an uncommon entity. Most common cases reported metatarsophalangeal joint injury as the most common injury of the forefoot. Close reduction is the usual treatment. However, there might be some difficulties in close reduction, especially if there are accompanied with plantar plate interposition or sesamoid bone interposition. Dislocation of the hallux IP joint is classified into two types by Mickey et al., which will be described later. In our case, attempt at close reduction was unsuccessful and the patient underwent dorsal approach open reduction, resection of the interposed sesamoid bone, and fixed with Kirschner wire. At this presented case, a 22-year-old man brought to our outpatient clinic complaining painful swelling of the left big toe for 5 days after falling from skateboarding. The patient was not brought to our hospital immediately because he was seeking for non-medical advice priorly. This is a common problem in Indonesia with less educated person. They were tend to seek for non-medical advice as their first choice. In there, he was given a massage and attempted to have close reduction by the help of 5 people without anesthesia, but unsuccessful. Because the complaint has not subsided, the pain still felt, the patient then went to our hospital for seeking for medical advice. In general examination, the consciousness is compos mentis and the vital signs were within normal limits. The local examination of the left foot, it looks bruised and hyperextended and swelling. The patient feels pain when the hallux IP joint is palpated, and the patient feels pain in both active and passive movement. As you can see here, the left big toe is in swelling and in extended position. The patient then underwent radiographic examination. From anterior posterior view, as you can see here, it shows interposed hallucal sesamoid between the IP joint. And from the oblique view, it shows dorsal dislocation with hallucal sesamoid trapped in the IP joint. Actually, the sesamoid bone is not shown clearly at anterior posterior view, but it shows more clearly at the oblique view. Dorsal dislocation of the IP joint of the great toe is a rare injury, as I mentioned before. The more reported case is in metatarsophalangeal injury as the most common injury of the forefoot. The instability of this joint is due to short lever arm of the distal phalanx, the condylar shape of the joint, the extensor and flexor tendon insertion, the short, thick, strong collateral ligaments that make the instability of the joint. The challenge is likely to be the interposed plantar capsule with the sesamoid. Up to 44% of the interphalangeal sesamoid is invisible radiographically.
Dorsal dislocation.
There are two types of irreducible dislocation depending upon the position of the displaced polar plate. In type 1, The sesamoid entrapped in the joint, radiographic reveals wider joint space, good alignment of the phalanx. So in this type 1, the IP joint is in neutral position. Intra-articular displacement of sesamoid displays resistance of dorsal and plantar flexion. In type 2, the sesamoid bone located over the proximal phalanx head, radiographic reveals narrower joint space and overlapping of the phalanx. And in type 2, the distal phalanx is in hyperextension position. From the patient's history, the mechanism of injury is suffering axial loading and hyperdorsiflexion. Close reduction under local anesthesia was attempted but unsuccessful. It is likely to be the result of unexperienced non-medical advice given before the patient came to our hospital. The interposed sesamoid effectively tightens the intercollateral ligaments. Close reduction becomes very difficult, if not impossible. Because the close reduction was not successful, the patient underwent surgical intervention. There's a dislocation of the IP joint is performing different approach. It might be approached by plantar medial, lateral medial, or dorsal approach. In this presented case, the patient underwent dorsal approach with open reduction. The sesamoid then shown interposing the IP joint, so it was removed. Sesamoidectomy is shown to be safe and effective for symptomatic relief as reviewed by many authors. After sesamoidectomy, 2.5 mm Kirschner wire was driven percutaneously to hold the IP joint in its native reduction. After surgery, the patient left victor was immobilized in spleen and elevation for 5 days. The patient was told to have followed up in first week and fourth week. In the fourth week, the Kirschner wire was removed and shows good result, although there is slight reduction of range of movement by 5 degrees, 3 to 5 degrees. The conclusion, the anatomy of the joint makes close reduction difficult to achieve. The challenge is likely to be the result of interposed plantar capsule with the sesamoid, and the patient underwent dorsal approach open reduction for interposed sesamoid bone and fixed with K-wire. It shows good result, although there is slight reduction of range of movement by 3 to 5 degrees. And that's all I have to present. Please have some input for me. Thank you.
Perioperative osteoporosis management in preoperative understanding of this. I am Professor Dr. Dilip Shah, attached to many hospitals of Mumbai like Saifi, Kambala Hill, St. Elizabeth, Nanavati Hospital. Osteoporosis is estimated to affect 200 million women worldwide. Osteoporosis is a silent epidemic. 1 in 3 women above the age of 50 years will experience an osteoporotic fracture. The lifetime risk of osteoporotic fracture in men aged more than 50 years is higher than the risk of prostate cancer. The voice of osteoporotic epidemic shows that only 1/3 of the vertebral fractures come to clinical attention, and underdiagnosis is a worldwide problem. Up to 80% of patients at high risk of additional osteoporotic fractures are never identified or treated. So we have the fracture cascade. If there is first vertebra fracture, it is threefold increase in osteoporosis. Second vertebral fracture, 5-fold increase. And if you have a fourth vertebral fracture, it is 8-fold increase. So that is the risk factor. Osteoporosis and osteoarthritis. Osteoporosis and osteoarthritis epidemiological profiles are similar. Bone metabolism plays a crucial role in the pathology. I'll take 1 minute to organize everything. Osteoarthritis is a heterogeneous disease in terms of staging, classification, location, risk factors, definition. Convergent and divergent risk. Osteoarthritis, if you have lifestyle, intense sport like high degree BMI, high BMD, overall injury load is increased. And osteoporosis lifestyle, if you are smoking and consuming alcohol, BMI is low, BMD is low, the load is because of immobility. So osteoporosis is assessed by techniques like DEXA scan, we call it as dual X-ray epsometry of the lumbar spine, hip and forearm, histological, high-resolution peripheral computer tomography. Osteoporosis in osteoarthritic patients, gender-wise prevalence of osteoporosis in osteoarthritic patients, 79% in females and 21% in males. Age-wise, the prevalence of osteoporosis in osteoarthritic patients is pre-operative arthroplasty. Patients are at higher risk for osteoporosis because of bone resorption and remodeling, with due to consideration of factors such as age and gender. Osteoporosis among awaiting TKR patients is 15.1%. So prevalence of patients on medication for osteoporosis awaiting TKR. So pre-operative arthroplasty patients are at a higher risk for osteoporosis because of bone resorption and remodeling due consideration of factors such as age and gender. Let's see osteoporosis and osteoporotic fracture post-TKR. Unrecognized osteoporosis post-total knee arthroplasty, incidence of periprosthetic fractures after total knee arthroplasty. So if you have a surgical issue of osteoporosis, difficult fracture fixation, poor screw purchase, excessive bowing, distal nail penetration, immobilization or minimal weight bearing causes bone locks and cause autogenous bone grafts are not much of any use. Osteoporosis increases complication risk even for fracture treatment because loss of reduction, secondary fragment dislocation, redisplacement, loss of radial or ulnar length, dorsal angle change, dorsal or palmar shortening, malunions, fracture impaction, delayed healing, non-unions. And if you have implants, primary malpositioning of the plate, primary malpositioning of the screw, and secondary screw perforation, implant loosening, plate or screw failure, breakage, radiolucency around the screws. If you have osteoporosis, that increases adverse post-operative outcomes. Early, there is dislocation, infraction, implant failure, and late, you have wear of articular bearing surface, osteolysis, mechanical loosening, and periprosthetic fracture. Dislocation, instability, implant failure, dislocation, instability, aseptic loosening, mechanical loosening, periprosthetic fractures very difficult to treat. So unrecognized osteoporosis post-TKR, DEXA scan is the current clinical gold standard to measure BMD and diagnosis of osteoporosis. The presence of a prior fracture identifies an individual as being high fracture risk and is considered an indication for pharmacological treatment by National Osteoporosis Foundation. Prevalence of occult osteoporosis meeting treatment guidelines after TKR was 36.7%. Risk of periprosthetic fracture after TKR, a cross-sectional study has shown more than 1/3 of the TKR patients are potentially at high risk of periprosthetic fracture and other complications related to osteoporosis. So the incidence of periprosthetic fractures after TKR is to be seen, and the incidence is 5 years postoperatively. The rate of fractures was 0.9% after THR, 4.2 after THR, 0.6 after TKR, and 1.7 after revision TKR. Risk factors for the periprosthetic fractures is age during surgery. Patients age more than 70 years at the time of primary TKR have increased risk. Female patients at higher risk, and revision surgery incidence raises after a revision surgery. So, female patients above the age of 70 are at significant risk of periprosthetic fracture after knee replacement. The use of adjuvant medical treatment may help reduce the effect of periprosthetic fractures. Recognition is most important. Orthos, often the first to see, assure all risk patients to have a follow-up. Develop a system in your hospital. Orthos own the bone. A prospective multicentric study on prevalence of osteoporosis in Indian patients undergoing elective arthroplasty and spinal surgery, I have named as PROPESI, and it has been published. Objectively, if you want to study this in arthroplasty, the bone implant interface needs to endure high shear stress of physiological loading. Poor quality of peri-implant bone may jeopardize the initial stability of cementless stems and also the long-term success of osseointegration, worsening the post-surgical outcomes. Therefore, this study is conducted to determine the preoperative prevalence of osteoporosis and osteopenia in Indian patients undergoing elective arthroplasty and spinal procedures. And this is the result: prevalence of osteoporosis or penia in patients undergoing elective procedures. The red is normal, osteopenia is light gray, and osteoporosis is dark gray. Bone quality assessment also showed significant difference, which you can appreciate over here. So assessment of 10-year fracture risk, 20% of the patients had moderate to high fracture risk. Conclusion from PROPESI study is sizable proportion of patients undergoing joint arthroplasty and spinal procedures in India have osteoporosis or osteopenia. Adverse postoperative outcomes and high risk of subsequent fractures can seriously compromise mobility and lead to high mortality rates. Implications for orthopedic surgeries: in view of the detrimental impact of osteoporosis in recovery of post-surgical outcomes, it becomes imperative to encourage pre-operative screenings and conduct a thorough bone health evaluation in all patients undergoing joint arthroplasty and spinal procedures. I thank you for your kind attention. I have finished my presentation, and if there are questions, I am ready to answer.
I'm from India, and presently I'm working as an SHO in Government Medical College, Kota. So, few months ago, me and my friends conducted a research, and our topic was examining the association between serotonergic, antidepressant, and blood transfusion in orthopedic surgery. Particularly, I'm very passionate about orthopedics, so this was my field of interest, and we proceeded with this. So starting on with my presentation. Yeah, so in introduction, selective serotonin reuptake inhibitors, also known as SSRIs, are extensively used pharmaceutical for the treatment of depression. Antidepressant medication usage has substantially increased in the past 2 decades, witnessing a notable shift towards the preference of selected serotonin reuptake inhibitors over tricyclic agents as the primary choice for their enhanced safety profile and improved tolerability. In your practice, how often do you encounter patients on SSRI undergoing orthopedic procedures? Potential association between SSRIs and increased risk of bleeding is seen over a number of case reports and observational studies. Why so? The serotonin release in platelet plays a crucial role in the aggregation process. Platelets lack the ability to engage in serotonin synthesis, instead relying on serotonin transporters to uptake serotonin from the bloodstream. SSRI exert their pharmacological effect by inhibiting the reuptake of serotonin transporters, hence reducing the concentration of serotonin inside platelets during a prolonged course of therapy. There were two studies which focused on examining the relationship between SSRIs and bleeding risk in perioperative period specifically. Results concluded patients who were on SSRI had a higher magnitude of blood loss and thus required blood transfusion more often throughout the orthopedic surgical procedures. However, the existing body of information regarding the perioperative treatment of SSRIs is limited, particularly in terms of determining whether these medications should be continued or discontinued. Existing evidence. The study conducted by Moving et al. Investigated the potential correlation between the use of SSRIs and the need for blood transfusion in individuals who had several orthopedic surgical interventions. The incidence of blood transfusion was almost 4 times higher in the group of individuals using SSRIs compared to those who did not use these medication. Van Helseth 2010 study further validated the previously mentioned associations. However, the clinical significance of these findings is uncertain, primarily attributed to the restricted number of cases demonstrating substantial preoperative blood loss. Hence, the aim of this study was to examine the relationship between the preoperative use of SSRIs and the extent of blood loss in surgical procedures, along with necessity for transfusion before surgery. Have you come across cases in which patient on SSRI experience increased bleeding during orthopedic surgeries? Probably the question for the orthopedic surgeons. So coming back to the research, the objective was the study aimed to investigate the association between the use of serotonergic antidepressant and blood transfusion requirements in orthopedic surgical patients. Study design. The study employed a retrospective design excluding patients without informed consent or those with missing or incomplete medical records or drugs prescription data. The primary focus was on the requirement for blood transfusion during surgery with secondary outcomes encompassing bleeding during the procedure, the necessity for infusion and drainage fluid loss. Prescription details were sourced from local pharmacies, and additional pre- and post-operative data were extracted from hospital records. What other factors do you believe could contribute to preoperative bleeding in orthopedic patients? So, covariant factors. The research investigated various factors that might impact the outcome, encompassing the utilization of medications such as corticosteroids, calcium channel blockers, iron supplements, aspirin, non-steroidal NSAIDs, I would say, vitamin K and antagonist. Further, more concurrent conditions like diabetes mellitus, renal disease, bleeding ulcers, and cardiovascular disease were considered as potential confounding factor influencing the association under scrutiny. Statistical analysis. Statistical package for social science version 25 was used to perform the statistical test. Results overview. A total of 170 patients were included in the study, broadly divided into two groups, with the distinction made between those who require blood transfusion during the surgery, and they were 78 in number, and those who did not require blood transfusion during surgery, and those were 92 in number. Preoperative hemoglobin levels were lower in blood transfusion group, that was 1.47 gram per deciliter, compared to the no blood transfusion group, which was 1.68 gram per deciliter. In terms of age distribution, A slightly higher percentage of patients over the age of 60 underwent blood transfusion, which were 53 in number, compared to the no blood transfusion group, which were 57 in number. Gender distribution showed that a larger proportion of females underwent both blood transfusion and non-transfusion procedures. Overview of study patients general characteristic, including subgroup based on blood transfusion requirement during surgery. So here we have divided in two groups, blood transfusion and non-blood transfusion, and there are different characteristics: age less than 60, more than 60, on the basis of gender, and then type of implant, elbow, knee, shoulder, and also anesthesia, which was general and spinal. Here we have a differentiated with other covariant factors like different medications, calcium channel blocker, corticosteroids, iron supplements, NSAIDs, as well as other disorders like diabetes mellitus, renal disease. These were the number of patients in both blood transfusion and no blood transfusion group. The usage of various medication was recorded, and it was noted that certain antidepressants, example, amitriptyline and imipramine, were more commonly used in blood transfusion group compared to the no blood transfusion group. NSAIDs were more prevalent among patients who did not require a blood transfusion. Morbidity and comorbidity percentage were also assessed, while diabetes mellitus, cardiovascular disease, and renal disease were relatively evenly distributed between the two groups. Bleeding ulcers were notably higher in the no blood transfusion group, as the usage of NSAID was also higher in that group. Table below illustrates a comparison of hematological measures between patient using serotonergic antidepressants and those not using serotonergic antidepressants. In the group using serotonergic antidepressant, 23% of the patients required blood transfusion, while only 4% did in the non-serotonergic antidepressant group, with a statistically significant p-value of 0.001. Regarding hematological parameters, the perioperative hemoglobin level showed no substantial difference between the two groups, with mean levels of 10.56 plus minus 1.16 gram per deciliter for serotonergic users and 10.62 plus minus 1.24 gram per deciliter for non-serotonergic users, resulting in a p-value of 0.07. However, the perioperative blood loss was notably higher in the serotonergic antidepressant group, which was from 0 to 7,500 ml, compared to the non-serotonergic group, which was from 0 to 6,500 ml, with a significant p-value of 0.001. Perioperative fluid infusion ranged from 300 ml to 5,000 ml for serotonergic users and 200 ml to 9,500 ml for non-serotonergic users, with a no significant difference, and the p-value was 0.24. Post-operative drainage ranged from 60 ml to 1,750 ml for serotonergic users and nil to 3,000 ml for non-serotonergic users, resulting in a p-value of 0.05, indicating a moderate difference. This table presents the odd ratio for blood transfusion in relation to age, sex, co-medication, and comorbidity factors. So, how can these odd ratios influence our perioperative assessment and decision making? I think this will make a difference. For the age group above 60, the odd ratio was 0.89, indicating a relatively neutral association with blood transfusion. Gender-wise, female exhibited an odd ratio of 0.79, suggesting no significant influence on blood transfusion likelihood. Patients on serotonergic antidepressant have an odd ratio of 2.51, potentially indicating an increased risk of blood transfusion. Non-serotonergic users displayed an odd ratio of 0.72, suggesting a wide range of possibilities. The use of iron supplements and NSAIDs shows odd ratios of 1.99 and 1.74 respectively, indicating the increased risk of perioperative blood transfusion. The increased risk was not found in non-serotonergic antidepressant, corticosteroids, or calcium channel blockers, and vitamin K antagonist treatment. Comorbidity factors yield odd ratios within specific ranges. Diabetes mellitus showcased an odd ratio of 1.03, implying a range of effects on blood transfusion probability. Cardiovascular diseases demonstrated an odd ratio of 1.42, suggesting potential varied impacts. So, discussion. Examined correlation between perioperative serotonergic antidepressant use and likelihood of receiving a blood transfusion of 2 or more units in orthopedic surgery patients revealed a threefold increase in risk of such blood transfusion among individuals exposed to serotonergic antidepressants during the perioperative period, indicated a statistically significant increase in blood loss during orthopedic surgical procedures among those prescribed serotonergic antidepressants compared to non-users. Case report provided evidence suggesting a potential association between serotonergic antidepressants and complications related to bleeding. Previous research demonstrated a significant link between serotonergic antidepressant and an increased likelihood of serious gastrointestinal bleeding, particularly in individuals concurrently using NSAIDs. Yang et al. In 2023 showed a threefold increase in risk of receiving 2 or more units of packed red blood cells transfusion. Comprehensive incidence research estimated a significant positive association between the total number of blood transfusions administered and the duration of hospitalization. Orthopedic and rheumatology patients who suffer from excruciating osteoarthritis often take NSAIDs before undergoing joint replacement surgery. According to Friedman, in 2013, NSAID increased the risk of perioperative blood loss in patients having total knee arthroplasty. Our most recent NSAID research supports these studies. In the present study, individuals taking calcium channel blocker did not exhibit an increased risk of perioperative blood transfusion. However, they did necessitate more post-operative blood transfusion. Our data supports the need for perioperative blood transfusions in orthopedic patients with rheumatoid arthritis, despite the fact that methotrexate administered intramuscularly to ambulatory individual is not inherently associated with higher risk of bleeding. A decrease in intraplatelet serotonin concentration influencing platelet aggregation is poised as the primary reason for the heightened risk of bleeding associated with SSRI. Surgical procedures themselves have been linked to a reduction in platelet serotonin and a concurrent increase in plasma serotonin. In surgical patients using SSRIs, the interaction of these two effects could potentially elevate the risk of bleeding by compromising hemostasis. Conversely, Anderson et al.'s study indicated a lack of significant necessity for blood transfusion in individuals who prescribed SSRIs before undergoing coronary artery bypass grafting. Investigation acknowledges limitations in considering variable beyond the specific exposure akin to previous observational studies. Unlikely significant impact of biases on finding information. Biases in improbable as serotonergic antidepressants are seldom linked to bleeding issues during routine orthopedic surgeries. Selection bias deemed insignificant, utilizing a well-defined population for patient sampling in the research. Minimal recall bias as all data were retrospectively collected, aligning the study's design. Hematological laboratory provided secure electronic data for endpoint definition. The study do has some limitations, including sample size and study areas. The research only included one hospital of the city. The results of a larger sample size may vary. Conclusion. The present study uncovered a noteworthy correlation between the utilization of serotonergic antidepressants and the need for blood transfusion. Given the widespread and the increasing prevalence of antidepressant use, the identified association between serotonergic antidepressant and the preoperative blood transfusion in orthopedic surgery possesses a potential health risk, particularly for older patients. This suggests a considerable likelihood for numerous patients being exposed to this hazard. The research underscores the critical importance of taking medication factors into account in preoperative management and emphasizes potential implications for refining patients' care strategies. Thank you, everyone.
Intracapsular neck femur fractures are venous compliant. So this was a study which we performed in the William Harvey Hospital, which is a district general hospital in the southeast of England. This is William Harvey here. This is my hospital, and it's just a map showing where we are. Okay, so to start off with, the National Hip Fracture Database, which we use in the which collates hip fractures in the UK. Note that there's 75,000 hip fractures every year, and the estimated incidence in 10 years' time is expected to be about 100,000 hip fractures. In 2018, we spent £1 billion on management of hip fractures, and that number is expected to increase by 3.6 to 5.6 times. Now, in the UK, we have National Institute of Health and Care Excellence, that's NICE, who provide guidelines on management of various pathologies, including management of hip fractures. So these guidelines, which recently changed, and what NICE suggests is that displaced fractures must be treated with arthroplasties. Total hip arthroplasty is recommended for patients with pre-op mobility of not more than a single walking stick, patients who are medically fit for an anesthetic, and who are expected to be independent with activities of daily living for more than 2 years. So the aim of this study was to assess compliance with the NICE guidelines and compare results with the national average. We performed a retrospective study. This is a single center study performed in a district general hospital in the southeast of England. We included only AO31B fractures, which were managed surgically. We included a time period of 3 months because the guideline was changed on the 6th of January, and hence we studied for a period of 3 months to assess what the compliance was. Now, when the guidelines were changed, this was discussed in the departmental clinical governance meeting so that all independent practitioners were aware of the change in guidelines. Now, the data was collected from the hospital hip fracture database. So over the period of 3 months, we identified 66 cases with a mean age of 79 years. And there's a breakup of the cases. And what we saw is that only 8 patients were offered total hip arthroplasty. A majority of them were offered hemiarthroplasties. And then furthermore, when we looked at cases which were eligible, we saw that only a third of the cases which were eligible for a total hip arthroplasty were offered a total hip replacement. And what we found was that the most common cause for not offering a total hip replacement was an ASA score of 3. ASA score of 3 was the most common reason why total hip arthroplasty was not offered. Now, what we did is we then further compared our performance with the national average, and we saw that the national average over these 3 months was 26%. And then we understand that our center ranked in the top 10 percentile in the UK. Now, NICE suggests that there are no studies which demonstrate a statistically significant reason to support the use of total hip replacements over hemiarthroplasty. However, they feel that THR would be beneficial and cost-effective in comparison with the hemiarthroplasty if the patient is expected to survive for more than 2 years. And what NICE suggests is that surgeons must use their discretion in decision-making to decide if a patient is expected to survive beyond 2 years. Now, what we find is that we hypothesize that the non-compliance is because of a lack of awareness of the guidelines. because of surgeon bias and perhaps proficiency in one procedure, and maybe a lack of perhaps a hip surgeon is not proficient in a non-hip surgeon is not proficient in performing a total hip arthroplasty. Furthermore, there's also a possibility that the ASA classification may have been performed incorrectly by orthopedic surgeons who are not particularly proficient with this classification, and as a result, there may be a tendency to classify patients as ASA 3 or more, and as a result, perhaps they did not receive an appropriate procedure. So to conclude, what we note is that a third of the eligible patients were offered a total hip arthroplasty. Pre-op mobility, American Society of Anesthesiologists score, and cognition are important factors which help with decision-making. And I think the current guidelines, the NICE guidelines, are rather subjective because they leave it to the decision of the surgeon if they feel that the patient is expected to survive for more than 2 years. And perhaps having more clearer guidelines, more objective guidelines would make it more, would improve the compliance. Any questions? And risk factors for venous thromboembolism following management of tendoachilles injuries in a weight-bearing orthosis. This was again performed in a district general hospital in the southeast of England. This is the William Harvey Hospital where I work. It's a district general hospital and acute center in Kent. So we know that tendoachilles ruptures account for about 29 to 37 injuries per 100,000 patients per year. And current evidence says that non-operative management, which is early rehabilitation, when compared with operative management, have equivalent rupture rates. Surgical treatment has a high risk of complications, almost 3.9 times that of non-operative management, an absolute increase in an absolute increase in the absolute risk of 15.8%. Now, immobilization of lower limb significantly increases the risk for venous thromboembolism. And there's multiple studies which suggest that venous thromboembolism when in tendoachilles ruptures can range from 1 to 52%. So we did a service evaluation. Our goal was to assess the incidence of symptomatic venous thromboembolism and to ascertain the risk factors which predispose to venous thromboembolism in patients treated in a weight-bearing orthosis. So this was a retrospective study. It was a single-center study performed in a district general hospital in the southeast of England. That's the William Harvey Hospital. All adults treated in a Vacoped boot for tendoachilles rupture were diagnosed either clinically or with an ultrasound scan. We excluded open injuries, bilateral ruptures, and if a patient had a concomitant injury in the same lower limb. And we began treating patients in a weight-bearing orthosis in the early parts of 2021, and we performed a service evaluation of our performance since then. This covered about a little over 2 years. Now, patients who were symptomatic with venous thromboembolism were investigated with Duplex scans or a chest CT in case of suspicion of a pulmonary thromboembolism. Now, this is the protocol that we use in our system. We follow it, we break it down into different phases. Phase 1, 2, and 3 involve patients being immobilized in a Vacoped boot, but we change the position of the ankle during these phases. In phase 4, we wean the patient off the Vacoped boot and we get them weight-bearing out of a boot. All patients immobilized in a boot are given venous thromboembolism prophylaxis with low molecular weight heparin, that's enoxaparin, and this is given for the first 3 phases. So what we note is that in our study, the mean age was 51.33 years. The incidence of DVT was 5.61%. That is 6 out of 107 cases. There were no cases of symptomatic pulmonary embolism. The average time of diagnosis of VTE from the date of injury was about 11 weeks. And we saw that 2/3 of our cases, almost about 66, 4 of these cases presented with thromboembolism between the 8th and 11th week. That is during the transition phase from immobilization of boot to no boot. So we performed a multivariate analysis, and what we found is that previous venous thromboembolism, coagulopathies, and were risk factors for VTE. We also note that non-compliance with anticoagulation is a risk factor. So the incidence in our study was 5.61%. And we note that in the largest study conducted in Denmark with over 28,000 cases, their incidence was 1.36%. And this was without any administration of chemoprophylaxis. Now, there's another large study which notes that the incidence of DVT was about 0.43%, and pulmonary embolism was 0.34% with chemoprophylaxis. And so the question is if there are low cases of, if there is a very low incidence of DVT without chemoprophylaxis, so is venous thromboembolism prophylaxis necessary? So in the UK, we fall back to the NICE guidelines, which provides guidelines for management of various problems. And NICE recommends that VTE chemoprophylaxis should be based on an assessment, and each patient should receive individualized chemoprophylaxis. And furthermore, there was a Cochrane systematic review, which notes that, I'm sorry, just one moment, please. Which notes that the chemoprophylaxis was 0.8%, was 2. And there was a higher rate in the control group. And this probably supports the use of venous thromboembolism. Now, there are concerns that non-judicious use of chemoprophylaxis may result in major bleeding. However, there's good evidence in systematic reviews that there's very little incidence of harm from chemoprophylaxis. There were no cases of major or minor bleeding in our series. All patients with the past history of venous thromboembolism and family history developed VTE in our series. The limitations to our study is that this is a retrospective study, and compliance with VTE chemoprophylaxis is patient-reported and may not be accurate. So to conclude, what I would say is that in our series, a high incidence of VTE supports the use of chemoprophylaxis in patients at risk. 4 out of the 6 patients in our series had risk factors. These include history of venous thromboembolism, coagulopathies. This was protein C deficiency in 1 patient, and non-compliance with anticoagulation again in 1 patient. And what I would suggest from our study is that a VTE assessment and individualized chemoprophylaxis should be considered. And future directions, it would be useful to have a larger study to assess appropriate dose and the duration of chemoprophylaxis for patients at risk. This is particularly important in patients who are at risk, because despite having chemoprophylaxis, they still subsequently developed VTE. So perhaps these patients at risk may require a dose adjustment. I'm now open to any questions.
Literature review of 2 autoimmune diseases that was presented in a boy of 27-year-old. And these autoimmune diseases like overlap features of EGPA, that is eosinophilic granulomatous with polyangiitis, and mixed connective tissue disease. I'm also very thankful to my other co-authors, Dr. Ruqayya Iftikhar and Dr. Muaz Shafiqur Rahman, to contribute for this. So first, we'll know what are the overlapping autoimmune response and diseases. We know when autoantibodies are developed against the self tissues, and they are not able to distinguish between self and non-self antigens, so producing so much autoantibodies destroying body's own cells and tissue. So we are well aware of these examples like rheumatoid, systemic scleroderma, systematic lupus erythematosus, multiple sclerosis, celiac disease.
So mainly we'll focus on EGP and MCTD response and its literature review and case report. So what is eosinophilic granulomatous with polyangiitis? So it is also known as Church-Strauss syndrome or allergic granulomatosis. So it is actually a type of vasculitis that is involving small and medium-sized blood vessels with the infiltration of tissues by eosinophilic and producing inflammations of vessels. So what are the clinical presentation of EGPA? So symptoms depend upon the stage and what kind of organ or tissue involved. Most commonly, like it is involving asthma. Like it is resembling with Wagner. So Wagner also involves asthma, but it's different from Wagner in the way like there are no eosinophils and like there is no peripheral neuropathy or there is no heart involvement, but EGPA is involving these things. So when we talk about the symptom, it can include nasal allergy, sinus problem, rash, fever, weight loss, joint and muscle pain, abdominal pain, GI bleed, and numbness, tingling in the hands and feet, irregular bleeding. So main manifestation is the skin involvement. So it can present as a purpura, small red or purple spots, nodules, or other skin lesion. So skin symptoms can be only one of the early sign of the EGPA. So neurological symptoms involves the manifestation of peripheral neuropathy like numbness, tingling, or weakness in the limbs. So how will diagnose the EGPA? So it depends upon the features, like what kind of feature the patient is presenting with, and will forward like for investigation like blood test, complete blood count, eosinophilic counts, and IgE levels. Will go for imaging like chest X-ray, CT scan, and eventually biopsy. So this is the diagnostic. So blood test will show high levels of eosinophils, like they can be seen in allergic reaction and inflammation. Imaging test mostly, as I told, X-ray and CT scan, they can reveal abnormalities in the lungs, and biopsies will show the granulomatosis, inflammation, and eosinophilic infiltration. So how will treat the EGPA? So actually, as we have discussed early, it is due to production of the autoantibodies. So we have to suppress that immune response and reduce that inflammation. So that's why we have to use corticosteroids or immunosuppressant. So corticosteroid we use like prednisone or methylprednisolone. For immunosuppressant, like we use cyclophosphamide. Biologics, in biologics we use infliximides. So treatment is usually long-term and require regular monitoring and follow-up. So next is mixed connective tissue disease. So it is also autoimmune, and it is a mixed manifestation of different other connective tissue diseases like SLE, scleroderma, polymyositis, dermatomyositis. So it is mainly diagnosed by the high titer of anti-U1 ribonucleoprotein antibodies. Sorry. So manifestation would be severe joint pain, stiffness, numbing, tingling, tingling in the hands and feet, weight loss, fatigue, night sweats, skin rash, rhinosinusitis, asthma, eosinophilia, and peripheral neuropathy. So you can see like these clinical manifestations are resembling with that of EGPA. So why it is makes, I told you, like it is involving features of many other connective tissue diseases I discussed. So what are the symptoms? We discussed this, like it depends upon the organ or tissue involved. We discussed this previously. So how will diagnose it? Same like clinical feature, blood test, sometime biopsy of the affected tissue. Mainly like it is based upon the clinical feature and the blood test, like raised level of U1 ribonucleoprotein antibodies. So main feature of the MCTD is Raynaud phenomena. So which is a condition that causes fingers and toes to turn white, blue, red when exposed to cold or stress. Skin rashes which may appear over the knuckle, elbows or knees, or as a red patches on the face or chest. Lung problem like SOB, cough, chest pain due to inflammation or scarring of the lung tissue or blood vessels. There may be heart problem, same as in EGPA, like inflammation of lining of muscle, like maybe endocarditis or pericarditis. Sometimes we can use biopsy, but mostly like its diagnosis is made by clinical feature and the high level of U1 ribonucleoprotein antibodies. So how will you treat? Same as EGPA, like we'll use corticosteroid prednisolone. It will reduce the inflammation. So then when we'll start other immunosuppressant agent will like stop or taper off the steroids. We can also use anti-malaria drugs like hydrochloroquine, which can help treat mild MCTD and prevent flare-ups. So they can also protect against sun sensitivity and skin rash, but they can have some side effect like retinal problem, nausea, or diarrhea. So immunosuppressant, we discussed previously, so metho, cyclophosphamide, azathioprine, mycophenolates, they can be used like in MCTD as they were used in EGPA. So we have discussed both the diseases. So we are now moving towards the combined risk factor for EGPA and MCTD. So both are autoimmune diseases. They can affect people of different ages and gender, but they have some differences in their risk factor. So some differences in their risk factor, like EGPA is more common in adults with a mean age of onset of 48 years, and has no clear association with the female sex. While MCTD is more common in young adults with a mean age of onset of 37 years and affects women more than men. Some genetic factors may be involved in both diseases, such as HLA DQ 2.5, HLA DRB1, 404, and interleukin 10 for EGPA, HLA DR4 for tumor necrosis factor alpha, and STAT4 MCTD. Some other environmental factors such as infection, stress, emotional distress, cold exposure, switching, or stopping medication may also trigger or worsen both diseases. So you can see these risk factors in the table as well. So here are some clinical studies that have discussed both diseases like EGPA and MCTDs. You can see like in 2023, Pio and its other authors like conducted retrospective cohort studies, and results were higher sensitivity and specificity than older criteria for diagnosing this arthritis associated vasculitis. So ANCA was more prevalent in GPA and MPA than EGPA. So like they concluded like older criteria was not so specific, and newer one is the most specific. And you can see other results of these studies, like the second one showed how interstitial lung disease was associated with MCTD. Third one shows like how different risk factor like smoking, silica exposures, and infections and drug were associated with the increased risk of this vasculitis. Then second last shows peripheral neuropathy was common in vasculitic patient and more frequent in granulomatous polyangiitis patient rather than in microscopic polyangiitis and eosinophilic granulomatous with polyangiitis. And the last one, the Miner, the study conducted by the Miner, they showed ANA positivity was more common and associated with MCTD, especially with SLA and the SS. So it is showing like autoimmune antibodies, they were more in the MCTDs as compared to other diseases. So here you can see the mixed clinical presentation of both EGP and MCTDs. You can see like joints pain, neuropathy, skin rashes, GI symptoms, rheumatic phenomena, weakness, and fatigue. They are common, while there are some differences as well. So what are our aims and objectives? So regarding this case report, so we are going to discuss a 27-year-old man that presented with a combined feature of these two diseases, like how we made a diagnosis and how we proceeded with the treatment. So now case presentation. So 27-year-old man presented with concurrent EGP and MCTD. These are two rare autoimmune diseases that affect multiple organs and have overlapping feature. So patient presented with severe joint pain, stiffness, numbness, tingling sensation in the hands and feet, weight loss, fatigue, night sweat, skin rashes, rhinosinusitis, asthma, eosinophilia, and peripheral neuropathy. You can see some features of EGPA and some feature of MCTD. For surgery is removal of all. So patient was diagnosed with EGPA based on the clinical feature, blood test, biopsy, antibodies, autoantibodies. So here you can see pulmonary hyperinfiltration. Then in the biopsy, we can see eosinophilic infiltration in the tissues. That tissues taken from the skin. So patient was treated with high dose of prednisolone, metho, hydroxychloroquine, cyclophosphamide, mesna. That is given with the cyclophosphamide to reduce its side effect of hemorrhagic cystitis, and supportive medication, and achieved early remission. In the diagram, you can see like erythema or paleness in the hands. So what are limitation of our case report? So it is describing mixed feature of both autoimmune diseases, but it has some limitation like lack of generalizability from a single case. So like our treatment cannot be generalized so much depending upon this limited number and qualities of studies reviewed. Like we have discussed only like 10 to 15 studies and put only 5 to 6 in the table. Potential publication and heterogeneity bias, and last one is need for, so there is need for more research to validate and update the finding. So what is my our conclusion? So this case reports tells a rare case of 27-year-old man who had both EGP and MCTD, two uncommon autoimmune disorder that are affecting multiple organs and have overlapping features. So the patient presented with severe joint pain, stiffness, numbness, tingling sensation in the hands and feet, weight loss, fatigue, night sweat, skin rashes, rhinosinusitis, asthma, eosinophilia, and peripheral neuropathy. So patient had past history of nasal allergies and asthma, underwent a FES surgery for removal of polyps. We diagnosed the patient with the diagnosis of EGPA based on clinical feature and blood test that shows high level of eosinophils, and skin biopsy that showed high eosinophilic infiltration in the tissues, while we made diagnosis of MCTDs with the investigation that is positive ANA, raised level of U1 ribonuclear protein autoantibodies and anti-CoO antibodies. Thank you so much. Any questions? Okay, thank you so much, all of you.
Thank you so much, Dr. Muhammad. It was an excellent presentation given to us. Thank you.
Okay, thank you so much. Thank you.
The main areas of our professional activity are orthopedics, spinal neurosurgery, and interventional pain management. And today, I would like to acquaint you with our experience in the treatment of chronic lumbosacral radicular pain. There is no conflict of interest in this work and off-label drugs and products using a bit of history. 1940s, first device for radio frequency destruction by Kosman. 1974, RF is used to treat of pain, and 1981, introduction of special cannulas expanse indication for radio frequency. 1998, beginnings of pulse radio frequency. General scheme of ref execution. The follows. The active electrode is located paraneurally. The passive electrode is located on the skin above the large muscle mass, for example, gluteal region or the scapular region. After connecting the radio frequency generator around the tips, active electrode and electromagnetic fields arise, which has, depending on the specified parameters, a therapeutic effect. On the right side of the slide, you can see radio frequency generator, a set of cannulas, active electrode, and passive electrode. The therapeutic field around tip active electrode is approximately 11 millimeter in diameter. It's necessary to distinguish between two fundamental types of radio frequency exposure, which can be set by the generator. This is constant type of impact and pulse type of impact. The result of this first is calculative necrosis. The result of the second is a change in the electrical conductivity properties of tissue. The pulse type of exposure was proposed in the mid-19th by Kosman. The generator produced bursts of pulses at frequency of 500 kilohertz with a duration of 20 milliseconds and at interval of 480 milliseconds. Large intervals do not allow the tissue to heat up about 42 degrees Celsius. In this aspect, the work of Erdin, published in 2009, is of great interest. According to the received data, the intrastructural components of axons have been found to show microscopic damages after exposure of PRF, including membranes and mitochondrial morphology and disorganization of microfilaments in tubules. Damage is more pronounced for C fibers than for A delta and A beta fibers. Thus, the therapeutic radiofrequency effect is distributed primarily to block the conduction of pain impulses. Motor and sensory fibers remain practically intact. A few words about epidemiology. Prevalence of lower back pain in developed countries is the size of the pandemic and serious, not only medical, but socio-economic problems as well. In the United States and countries of Western Europe, the prevalence of lower back reached 18%, the annual incidence 5 persons. It's the second most common after respiratory disease, the reason for going to the doctor, and the third by frequency of hospitalization. From different categories of lower pain, we will focus on the specific discogenic and radicular, since they often coexist. Connection of lumbar pain with IBD irritation was established by Hirsch in 1948. Later, the data were refined by Nikolai Bogduk. During this degeneration, not only a germination of nerve fibers in the central section of the disc is observed, but also an increase in the density of its innervation. In the nerve fibers of the disc, the spinal nodes, reactivity to the substance P was found. At least some of the fibers and receptors of the disc are receptive, and their stimulation can be source of discogenic pain. And multi-response experimentally can lead to a change in the phenotype of neurons, as a result of which most of them become nociceptive. One of the intervention methods for treatment of discogenic pain is IDET, intradiscal electrothermal therapy, a minimally invasive method for releasing heat energy into the antivertebral disc. Radiofrequency electrode catheter system, disc rod or flex rod, used heat to coagulate the receptive and decompress the disc. Stepwise increased from 50 to 65 degrees. You can see the patient in prone position, the marking of the surgical field. The catheter system is installed into intervertebral disc. Contrast discography in AP in lateral view. In the treatment of radicular pain, the tunnel imaging method is used to access dorsal root ganglion, DRG. Shifting the C-arm beam to the ipsilateral side, X-ray anatomy Scottish dog. Target point is under the dog eyes with tunnel vision. Next slide, you can see operation theater. Operation, the patient in prone position, the electrode is placed paraneurally with the dorsal root ganglion. The root is contrasted with Omnipac 2 series of 120 seconds. All manipulations are performed on the outpatient basis in the operating room under fluoroscopic C-arm or ultrasound control. With constant venous access, monitoring of indication, vital function is carried out. The operation room is equipped with everything necessary to intensive care, artificial ventilation, cardiopulmonary resuscitation. The duration of this procedure is up to 40 minutes after the manipulation, an hour of observation patient carried out. But there is a problem. Pulsed radiofrequency of dorsal root ganglion leads to a very long-term effect, but does not eliminate the mechanical cause of pain, a degenerative altered intervertebral disc. IDET, intradiscal electrothermal therapy, directly affects the intervertebral disc, changing its structure and reducing intradiscal pressure. However, the pain manifestation of radiculopathy itself regress later, which can be but worse patient's quality of life. Thus, we proposed to combine these two methods. The combined action protocol consists of 2 parts which are performed simultaneously. The first part is to perform thermodiscoplasty, high frequency current is supplied to the intradiscally installed electrode catheter in a constant mode. In this case, the working part of the catheter is heated stepwise from 50 degrees up to 65 degrees, or 120 up to 240 seconds each. Thus, thermal modification of collagen fibers and the activation of nociceptors are achieved. The second part, pulsed radiofrequency dorsal ganglion, was performed in a pulse mode, which, due to influence primarily of nerve C fibers, reduced the conduction of pain impulse. 2 series were performed, lasting 120 seconds each, during which the temperature of electrode tip should not exceed 42 degrees Celsius. Pulses with frequency of 500 kilohertz. The duration of each is 2 milliseconds. Now you can see intradiscal electrothermal therapy L4-5 disc, and the left a pulsed radio frequency L4 root. On the photo of intraoperative fluorogram in AP, and appearance of surgical field. Black arrows indicate the intradiscal catheter for thermodiscoplasty, and white arrows indicate the electrode for radiofrequency pulse ablation for the posterior spinal root ganglion. Traces of the radiopaque solution for provocative discography and visualization is the intervertebral space. The spinal root L4 left also contrasted. Our methods is protected by the patent of Ukraine. The owner of the right is Uzhgorod National University. And our first results. The results of treatment were evaluated by pain visual analog scale and disability index osteohistory ODI. The main criteria evaluation of treatment results were pain intensity and dynamic of social adaptation. An assessment has been made indicators before treatment, directly after the manipulation, after 1 month, and after 6 months. Complications during operation and after them were not observed. Significant analgesic effect observed immediately after intervention. Most patients in preoperative period were characterized their pain as terrible, leading to distress rating from 6 to 9 with visual analog scale, by visual analog scale. And already on the first day after surgery, maximum number of patients described the pain as weak but troubling, which correspond from 1 to 5 visual analog scale. Often this had uncomfortable feeling, myogenic character caused inevitable soft tissue injury during excess. The treatments result in 1 month after operation testified about maintaining a downward trend pain syndrome. More than 60% operated were celebrated almost complete absence of disturbing sensation, and about a third of patients characterized pain as weak visual scale 2.18. Similar results were kept for 6 months when patients evaluated their own pain according to us from 1 to 3. Wealth of attention, in our opinion, data obtained using osteohistory pain disability scale. So before treatment, disability was determined in the patient range from 60 to 80 points on ODI, which is sufficient low vital energy, and already after 1 month of the surgery, most patients could stay much longer in vertical position, which allowed them to participate in public life and also make long trips. Many of patients would care without using analgesic. A significant part of the research the normalization of sleep. This trend continued after 6 months until the end of our period observation. Patients characterized the degrees of social adaptability by ODI in the range of 14 up to 50 points. In conclusion, combined use of IDET and PRF-DRG is effective and safe method treatment chronic therapeutic resistant lower radicular pain associated with protrusion intervertebral disc. Published first results of our experience interested colleagues from Spain, Italy, India, USA, and United Arab Emirates. Unfortunately, the coronavirus pandemic did not allow us to take part in representative interventional forums, alas. However, our research on this issue is ongoing, and we are confident that we will soon provide you with more extensive data on this view, which will include more than 200 cases, but this is in perspective. Sincerely and extremely grateful, I appreciate your time and attention. I would like to once again thank organizers of Congress and personally Laura Valentin for the invitation to take part in such representative forum. Believe me, it's a great honor for us.
Thank you so much, Dr. Boris. It was an excellent presentation. Hope the participants have learned and benefited.
Combination osteosynthesis of 3 and 4 fragment fractures of proximal part of humeral bone. Exist to date a large number of studies and the results regarding adhesion treatment of multifragmentary fractures of the proximal humors does not give a clear answer to identify the optimal method of osteosynthesis. Most orthopedic prefer prosthetic proximal shunt. However, the working age of patient, the need of repeating reprotections in the future tend to the choice of primary osteosynthesis. In this slide, you'll see different type of osteosynthesis, prosthetic, arthroplasty. But in classification, as you'll see, only the bone structure, different type of classification. In now it's Neer, Codman, Lego classification, but tendocapsular apparatus of the joint is very important to the good result in the future. If we'll see in this slide, you'll see more different type. It's static stabilizer of shoulder, dynamic stabilization. If a static, it's a lumbar of scapula, dynamic, it's a rotator cuff, biceps tendon, and if you'll see moving, bone maybe only little moving in the shoulder, only up, knee, and a little around. But if we see with tendon capsule apparatus, we may do different types of moving in our shoulder. Deltoid muscle, it's up, next terms mean term, it's rotation, subscapularis, and only in this complex we have a good result of treatment of our patient. Improving the result of treatment of patient with fractured proximal part of humeral bone by applying a system of combined osteosynthesis to repair the damaged segment with the understanding of its structure. It's aim of my work. Background date most research and was the use of osteosynthesis for the use of polyaxial lock and compression plate only on prosthetic for multiple fracture of the proximal humerus. However, the use of lock and compression pant alone does not make it possible to fully to restore the proximal humerus. Prosthetic in young patient brings many questions. Therefore, a combined method of osteosynthesis is required to restore the bone and texture and the tendon capsule apparatus of the joint shoulder. All surgeons who treat the patient with proximal part fractures of shoulder want to be a good result after treatment. And like this picture, how our way to this result. 2008 and up to the present time, the study group consisted of 324 patients with a multifragmentary fracture of the proximal femurs. This type of fracture in all patients was accompanied by a rotational component of more than 45 degrees and a distance between fragments of more than 1 centimeter. Age of patients from 26 years old to 83, mean age nearly 55. There were 184 men and 140 women. All patients were operated according to the development method until a model patient of register in Ukrainian state register of patents of Unity model. In preparation standard radiology and the computer scan with reconstruction and of the injured segment were used to determine bone damage. To determine the damage of the tendon capsule, ultrasound, and in some cases MRI of the proximal shoulder. Let me introduce some clinical case of patients. In this slide, you'll see patients 33 years old with 4-fragment fracture, prepared to operate in its computer diagnostic and next operating. In this case, I will do, first of all, intraosseous osteosynthesis with anchor fixation. If you'll see on our model, when we have only plate, we have a problem zone area of lower tumor. Plate, good and great fixation, great tuber shaft and head, but this zone is problem to contact in the future. And our need to plus next fixation of anchor fixation and transosseous osteosynthesis and LCDs, we have a good result. And next, have a good contact in area of lower tumor. Next clinical case, patient 66 years old with 4-fragment fracture. In this case, we have next step of our treatment. First of all, base it's osteosynthesis with lock and compression plate. And next, as you'll see up, we have a problem with low tumor. And next fixation, transosseous osteosynthesis with anchor fixation. And finally, we have a good result. We have a good fixation with plate and fixation with anchor lower tumor and rotator cuff repair. Clinical case patient 76 years old with 4-fragment fracture, little dislocation of head. We have same, first of all, it's a fixation of lock and compression plate, and next transosseous osteosynthesis with repair rotator cuff and tenodesis of tendon of long caput with anchor suture. And we have good fixation and good result. This clinical example, patient 57 years old, interesting, then have a 4-fragment fracture, but not total damage of rotator cuff. And in this case, we'll do osteosynthesis with lock and compression plate and simple reinsertion of rotator cuff with anchor suture. In the postoperative period, the constant Murley and Dash score were used to determine to the recovery of upper extremity function. All patients accept standard lock and compression plate osteosynthesis, underwent intervention on the tendoacapsular apparatus of shoulder joint to restore its integrity. Multiflammatory fractures of the proximal humerus used tendoplasty of the rotator cuff, as there was a need to restore normal muscle tone of rotatus. Certainly, not all patients may only with osteosynthesis our methods. If you have elderly patients like this, 84 years old, with multifragment fracture, with problem of humeral head, it's a vascular necrosis and multifragment fracture of great and low tuber. In this case, the good way only reverse prosthetic arthroplasty, and patient have a good result of our treatment. But it's theme of next. Conclusion. First of all, patient with multiple fracture of the proximal humerus require two-stage. First, it's restoration of bone anatomy. Second, reconstruction of tendon capsule apparatus of the shoulder joint, approach during surgery. The high percentage of combined lesion, bone and tendon capsule causes him to pay more attention to his diagnosis both during the preoperative period and during surgery. And the third, the obtain positive functional results of treatment of patient make it possible to use the development technique in the treatment of patient with this type of injury. Thank you for your attention. Peace for all and peace to Ukraine. Have you any question for me?
Thank you so much.
Fractures. It's supervised by University Clinicum in Bochum in Germany. Now, so the first description of proximal tibia fractures dated back to 1825, where Sir Astley Cooper recommended the treatment of proximal tibia fractures by alignment, splintage, and early passive motion. And then in 1973, came Rasmussen and introduced the Open Reduction Internal Fixation in terms of cerclage wire, as we see on the second picture. And 6 years later came Schatzka and described his first classification, which is commonly used till today. Now, due to the involvement of the articular surface fractures, the improper treatment of tibia plateau fractures can potentially result in unfortunate prognosis. And this operative intervention with anatomical reconstruction of the joint structure, including restoration of the coronal and the sagittal plane, is often indispensable to achieve a satisfactory clinical outcome. Now, as we know that the indication of RF, they are the stop of deformity, which is more than 3 millimeters, condylar widening, which was more than 5 millimeters, plateau tilts about more than 5 millimeters, and plateau slope, which are common in the literature. Now, how we predict the failure of fixation after RF? Now, the little attention has been paid to a standardized definition of failure of a reduction after RF of proximal tibia fractures. So now, in order to answer this question, we performed a literature review, and we found that there's no more than 150 articles that addressed the standardized criteria that define failure of fixation, with most adopting the same criteria that defines the indication of a primary surgery and not for revision surgeries. Now, To elaborate more on this topic, an experiment was done in 1990 on a cadaveric model and with the minimally displaced tibia plateau fractures. And this showed that the pressure on the cartilage on the side of the fracture become progressively greater, and this subsequently lead to early osteoarthritis. Now, the same or modern experiments with fracture synthetic bone fixed with plates and screws have shown that the induced plateau depression or step deformity, which we call, of 2 to 3 millimeters, so just 3 millimeters, was enough to cause a force shift of up to 60 degrees, as we see here on the right side of the picture. While a step deformity of 5 millimeter, which in the normal case in our surgeries, we can sometimes adapt 5 millimeter deformity. This can synthetically form a force shift of up to 80%, which is a big number. So basically, more attention is being drawn on the importance of tibia plateau depression, but no clinical association has been established in any of the previous studies. So here we came to our hypothesis that the postoperative CT measurements can anticipate failure of fixation after RF in proximal tibia fractures. So between 2016 and 2019, 69 consecutive patients with fractures of the proximal tibia operated at our center in Minden were studied. Now, 7 patients, as we here see, were excluded, and the demographic data was collected. Post-op CT scans were evaluated to determine Chaska classification and to assess the reduction and alignment of the fractures. Now, patients' medical records were retrieved up to 12 months post-op, and a clinical assessment of each patient was conducted. And as we can see by the demographic distribution, that Chaska type 2, which has 43% of the cases, which was predictable, then followed by Chaska type 4, and then type 5, and then type 6. Now, the patient and injuries characteristics, as we can see, multiple fragmentation was seen only by CT scans up to 72%, soft tissue injuries, including ACL rupture and meniscus rupture, up to 24%, open injuries 5%, osteoporosis, and there was a slight male gender of 54%. So, speaking a little bit about our operative approach, the surgical approach followed the fracture pattern as well as Chaska classification. That means type 2 classification according to Chaska received a lateral column buttress plate to prevent secondary valgus deformity via a standardized lateral or anterolateral approach. Now, type 4 Chaska classification received a medial column buttress plate to prevent varus deformity, and a double plate system was used in type 5 as expected, and type 6 fracture depending on the fracture pattern. So to elaborate more about our approach, as we see here by step of deformity, so reviewing our 62 post-op CT scans on the coronal view, so the AP view on the CT scan, the articular surface depression or the step of deformity was measured as a vertical line from the point of maximal depression of the joint line. As we see here, this is it, no? And so what about the condylar widening? How could we measure it? As we see on the diagram, it was measured on the axial plane as well as the horizontal distance from the point of maximum fracture fragment. Now, one would ask, why wouldn't we do this measurement in comparative with the other side? Because always the contralateral side is a more reliable measurements. We didn't do this because of the CT scan measurements. We weren't able to do CT scan for the healthy bone for 69 patients. This is because of X-rays reasons. So the only source of our measurements was the ipsilateral side. Now, again, the plateau slope was also measured on the axial as defined as the angle between the tibia plate surface and the long axis of the tibia. And the posterior tibial slope, as we see here, was defined as the angle created by the tibia plateau and the long axis of the tibia in the sagittal plane. So also here we can see that the posterior slope was defined as the angle created by the tibia plateau and the long axis of the tibia on the sagittal plane. So this is how it looks like, our study. So pre-operative CT scan, we draw this line and we measure the step of deformity as well the condylar widening. This is on the sagittal plane as we see the tibia plateau. The horizontal, we measured here on the axial plane, the distance between the fracture fragment, and we have the 3D image. Intraoperative measurement, unfortunately, we don't have intraoperative CT, but all we have is the intraoperative imaging X-rays, which was enough in this case. And as we see the post-op CT measurements, so all the patient received a post-op CT scanner in order to measure this step of deformity. The same calculation was done. And now coming to the results, within a 12-month follow-up period, of the 62 patients in our study, 5 of them underwent revision surgeries after RF, mainly because of persistent pain and inability to bear weight. So consequently, we revised more closely the CT analysis of these 5 patients, and interestingly, we found that all have a step of deformity of more than 3 millimeters. And between all the criteria measured, and it was the only one that was statistically significant, which is the step of deformity. So we came to our conclusion that post-operative tibia plateau depression greater than 3 millimeters on CT scans is highly predictive of fixation failure. The plateau tilt or the condylar widening and slope inclination were not an important factor for failure of fixation. That was my talk. Thank you a lot for listening. And if you have any questions, we would love to hear them.
Thank you so much, Dr. Sir. It was an outstanding presentation, and
about ozonotherapy in discrimination and advanced treatment. I'm Professor Dr. Massimo Piracci. I work in Dubai in the Medcare Orthopedic Spine Hospital. So we start to what is ozono? Ozono is a stable allotropic form of oxygen that impacts an oxidation activity with various biological components. We see that the first science that invented the ozono generation was Nikola Tesla. This was a long time ago in 1896. And by exploring this mechanism, clinicians have utilized ozonotherapy as a topical and systematic agent in treatment of various conditions. So ozono has been subjected to criticism and emphasis in relation to clinical efficacy and toxicity respectively, but despite these various options and healthy controversy on ozonotherapy, the practice of this therapy have increased worldwide. Ozono has a great oxidizing activity as a soluble gas. When it is in contact with the biological fluids, it forms reactive oxygen species that we call ROS, and as well as lipid oxidation products we call LOP. Both of these products react with white blood cells, initiating the formation of proteins, cytokines, and red blood cells, which increase the tissue to oxygen supply. So the ozono, when entering the system, it reacts with biomolecular like PUFA antioxidants present in the plasma. The reaction adds hydrogen peroxide and lipid oxidation products. This is we have in the early phase, we get these ROS, and in late phase we get the LOPs. This is very important for the action that we have in our body. So the sudden rise in plasma concentration of hydrogen peroxide generates a gradient, which causes its rapid transfer into blood cells, where in a few seconds it activates several biochemical processes and simultaneously undergo reduction to water by efficient intracellular antioxidant action. So the critical step corresponds to a controlled, acute and transient oxidative stress necessary for biological activation without concomitant toxicity, provided that ozone gas is compatible with the blood antioxidant capacity. While ROS are responsible for immediate biological effects, lobes are important as late effectors when the blood ozonide ex vivo return in the circulation. We can see here that when the blood ozonides return in the circulation, the lobes can react with many tissues. So this is the biological effect, where the ROS, they have a very early action with erythrocytes, leukocytes, and platelet, while the lobes has a late reaction with the endothelium, bone marrow, and other organs. The application of ozonotherapy are many, from topical to dental, treatment of cancer, treatment of AIDS.
Hello, Dr. Muslim.
Yes.
Sorry to interrupt. Your slides are not moving, doctor. Kindly check with it.
It's not moving?
Yeah.
Can you see now it's moving?
So now it's fine, doctor. You shall proceed.
Okay, because I went in presentation anyway. It doesn't matter. I will show like this. Okay, so now it's okay. Yeah, application of ozonotherapy. You see this slide, right? Emily, is okay?
It's fine, doctor. You shall proceed.
Okay. So the application, as I told before, we have topical dental treatment of cancer, AIDS, treatment of severe acute respiratory syndrome, neurodegenerative disease, diabetic foot, and COVID-19. The advantage and the disadvantage of ozono, the advantage is prevent the oxidative damage and act as a disinfectant. We know that, for example, for the water in the swimming pool, we can use ozono instead of chloride for the disinfection of the water. And disadvantages are hazard to the skin cell, and the red blood cell clamping is lessened or eliminated by ozone. So for the lumbar herniation, we speak about etiology very fast. The more men in the third and fourth decade of the life, obesity, diabetes, smokers, driving for long hours of physical demanding work, genetic predisposition, acute trauma, and mobility. This is the anatomy and biomechanics of the structure of disc, intervertebral disc. We can see that the disc is formed by the annulus, where the lamella of the annulus fibrosus plus the nucleus pulposus. So what's happened that in this case with the disc herniation, there is a degeneration of the annulus. So there is a tear in the lamellae, and can be happen a prolapse of the disc or a disc herniation. So according to the Cummins analysis of patient enrolled in the vertebral disc arm of spinal patient outcome research sport, the average was of 41 years old. Men were diagnosed with the condition slightly more than the woman. Patient which BMI 25 to 30 were more developed lumbar radiculopathia and strenuous physical activity, patient with high stress job and with lower job satisfaction, and significantly higher rates of lumbar disc herniation. The physiology, we can see that the aging of the disc till trauma, then there is the disruption or tear of the annulus fibrosus and the disc degeneration with the discogenic back pain. Here we see also the rule of the vessel that, as in the annulus, where there is a calcification of the endoplate, so the subchondral plate is degenerated and the disc became smaller. This is very nice image where we can demonstrate that if we do a MRI in 3D, we can see better than a normal MRI because there is a better view of the herniation, and we can see that the disc, for example, in this case is L2, L3, there is the split of the posterolateral ligament, and also in the dura madre we can see the decompression on the coda equina. So it's very high impact the 3D sequence for the MRI. The treatment, we have several treatment from medicine to support analgesia and relaxation, till anesthetic and corticosteroid to block the effect root. Then surgical treatment, there is absolute indication with coda equina syndrome and relative indication when we try to treat the patient for at least 6 weeks without any improvement and with the motor deficit grade 3, and sciatica for more than 6 weeks. The surgical technique, there are many techniques, but the microdiscectomy is better than the open surgery. This is due to a less aggressive and less complication rate for the bleeding and the duration of the procedure. And ozonotherapy has a very important role in this treatment, and where we can use this ozonotherapy in different way. But in the concentration optimal for the intradiscal is 27 microgram per ml of oxygen. The mechanism action of ozonotherapy in the lumbar disc herniation is there is a precipitation of the proteoglycani of the nucleus, and there is a fibrosis, fibrosis inside of the nucleus that in 5-6 weeks start a new regeneration of the cell. So there is a healing of the disc. So this is what I told you just now. There is a substantial cell degradation of the matrix and release of the water molecule. The matrix is replaced by fibrous tissue and formation of new blood cell in approximately 5 weeks. So there is a reduction of the disc volume is the result. So the disc shrinkage can improve local microcirculation and increase the supply of oxygen by reducing venous stasis caused by the disc compression of the vessel. So also the vessel, the vas plexum reduce the pressure on the disc. Ozone also has anti-inflammatory effect in treated disc herniation. This action tied into inhibit the release of bradykinin or release of allergenic compounds, as well as inhibit the synthesis of pro-inflammatory prostaglandins. Pro-inflammatory cytokines, such as interleukin, can be neutralized by increasing release of antagonists. Selection criteria for ozonotherapy is radicular pain rather than low back pain. Patient must have pain in a well-discriminated and constant cutaneous dermatome with positive LASEK test, and pain should score 5 or more than the visual analogy scale VAS. Absolute contraindication is referred allergy to proposed drugs. Relative are pregnancy, G6PD deficiency, hyperthyroidism, severe anemia, severe myasthenia, recent myocardial infarction, and history of mental disease. So this is a review done for some papers, and we can see that the result of all of them, we have a VAS score that increase degrees from high to low, and the best result anyway is at 6 months. Same for the disc herniation. I will go very fast because the same story. The symptoms we have also in this case, we have cervicobrachialgia with numbness and discomfort on the arms. The pathophysiology may be developed as a result of a single or severe strain or injury. With aging, the ligament that keeps the disc in place starts to deteriorate naturally, and the relatively minor strain of twisting motion may interrupt a disc as a degeneration worsens. Pain management also for the cervical is self-care of the neck, so short period of rest, ice or heat. Activity modification, so we know that now the problem is there is a new syndrome that is mobile syndrome. Many patients are affected of this problem because the neck is not in natural position. So also the work on the computer, so the lifestyle is important. Then also in this case, medication, physical therapy and epidural injection, but also the ozonotherapy has a very good result. Patients with neck pain or radiculopathy corresponding to disc herniation without cervical cord compression are most suitable for ozonotherapy. So ozonotherapy is minimally invasive treatment that provides anti-inflammatory effect and pain relief by oxidizing protoglycan in the nucleus pulposus, leading to the shrinkage of the disc, which compresses the nerve root, a powerful stimulus to the activation of antioxidant defense is the result of ozono injected in the peridural space of the colligation foramen of and the disc. Also here we can see, I did a review of the literature, and also here we can see there is a significant improvement with the VAS that the score between 2 and 6 months improve very, very well. So the safety profile of ozonotherapy in the systematic meta-analysis of the therapeutic result of percutaneous injection of ozono for low back pain, secondary disc herniation for long-term pain relief was found to be 2-3 for ozonotherapy applied intradiscal and 2-1 for ozonotherapy applied paravertebrally. So the grading of recommendation was 1C for intradiscal ozonotherapy, 1B for paravertebral ozonotherapy. The complications are very rare, but we can maneuver between this one, severe headache, cardiopulmonary arrest, anterospinal cord syndrome, acute myocardial infarction, transcortical bleeding, few temporal episodes, and paresthesia and hypoesthesia. I'm doing ozonotherapy since 30 years, and I never had any kind of this severe complication. So the conclusion, the literature confirms that minimally invasive therapy with oxygen ozono is safe to use through percutaneous injection for treatment of lumbar and cervical pain, particularly when compared to surgery and drugs therapy. The ozonotherapy became an effective treatment option as it promotes tissue hyperoxygenation as well as treating painful syndrome affecting muscle, tendon, joint. Through ozono, as indicated great success in most indications mentioned, there is still need to be further research conducted to determine its activity in order to prevent the common side effect that ozonotherapy causes. It is essential to continue researching the utility of ozonotherapy in all the indications. This is some picture where I do ozonotherapy percutaneous in the paravertebral muscle. This technique is very safe if it's done by expert hand. Thank you very much.
Thank you for your excellent presentation, Dr. Massimo. Thank you so much. Moving on.
If there is any question.
Our index case was a 21-year-old male patient who presented to our emergency department after being involved in a road traffic collision in a moped versus car incident. He was otherwise fit and well and was not using any medications, and there was no significant family history. Examination findings. On primary survey by ATLS examination, the significant findings were an isolated left lower limb injury with a deformed and extremely painful ankle. There were no other injuries to the long bones, pelvis, head, spine, or other extremities on primary and secondary survey. Clinical examination of the left ankle revealed a deformed sublux left ankle with no open wounds and strong capillary refill with good distal pulses. These are the initial radiographs after 3 attempts at reduction in the emergency department under Penthrox. All 3 attempts were unsuccessful, suggesting a soft tissue interposition. The operative procedure. The lateral side was addressed first. The standard lateral fibular incision was used and the fracture was reduced and fixed with a 3-hole 1/3 tubular plate. Tension was then turned to the medial side and exploration of the medial side revealed the empty groove sign. The wound was then explored anteriorly to show a complete subluxation of the tibialis posterior tendon. So the deltoid ligament was taken down and the tendons were explored and reduced posteriorly. The tendon sheath and the flexor retinaculum were repaired along with the deltoid ligament, and the final position was much improved and acceptable. Post-operative duplex scan confirmed normal arterial supply. Post-operatively, the patient was kept non-weight bearing in a back slab for 2 weeks and a splint for another 4 weeks and advanced to full weight bearing at 12 weeks. These are the intraoperative images. The operative findings of significance were the complete anterior subluxation of the tibialis posterior tendon, FHL and FDL over the medial malleolus along with the rupture of the flexor retinaculum. This caused persistent subluxation of the talus. There was also complete rupture of the deltoid ligament and short transverse Weber B fracture. Follow-up. The patient was followed up for 6 months post-operatively and recovered excellently with no complications. At 6 months, he was walking unaided. He is now 2 years out of his injury and came back with no issues. Discussion. Irreducible ankle fracture dislocations usually occur due to high-energy trauma, such as road traffic collision or falls from height and are pronation-type injuries. This mechanism causes the tibialis posterior tendon to subluxate laterally and anteriorly at the time of the injury, and any attempts at reduction causes entrapment of the tendon between the talus and the medial malleolus. Inability to recognize tendon interposition can lead to disastrous complications such as tibiotalar osteoarthritis, equinus deformity of the foot, and clotto deformity. Most patients often undergo second and third surgeries due to failure to recognize soft tissue interposition in early stages. In conclusion, inability to achieve acceptable reduction of an ankle fracture dislocation suggests soft tissue interposition in high-energy ankle injuries. Image intensification should always be used to confirm the reduction, and non-anatomic reduction should not be accepted. Persistent anterolateral translation of the talus on image intensification intraoperatively strongly points to the interposition of tibialis posterior tendon and should be addressed. As regards to the approach used, we feel it might be advantageous to use the medial approach initially when the entrapment is expected. No sooner than the soft tissue restraints are removed than the ankle can be reduced. Thank you.
Thank you so much, Dr. Madhavi. It was an excellent presentation. Thank you so much.
Thank you.
Polyvenile implant for a patient with Freiberg's disease. It's a foot and ankle specialist subject, and it'd be interesting to have a chat about it. So next slide, please. Yeah, so basically, just to give a brief chat about Freiberg disease. Freiberg disease, well, you know, we know it's a disease of the forefoot when it comes to foot and ankle. And it's basically, you know, it was first described in 1914 by Dr. Albert Freiberg. And what it usually means is that, you know, well, when he saw 6 patients, And they were all female patients, middle-aged, and they had pain in the ball of their feet when associated with weight bearing. And he noted that radiographically, they had a crushed second metatarsal head with loose bodies within the metatarsal head. Basically, well, it was noticed that it was characterized by osteochondrosis of the second metatarsal head in 68% of the cases and 27% of the cases in the third metatarsal head. The most common demographic is female athletes, and we still don't know what the reason for the disease is, but it's accepted that it's a multicultural, a multifactorial cause. It's with microtraumas, abnormal mechanics, and the main theory that's flying around is arterial insufficiency. So next slide, please. Yeah, just to talk a bit more about Freiberg disease. In advanced stages, there's a collapse of the articular surface, and there's some dorsal impingement and some damage to the dorsal aspect of the articular surface, which causes a lot of the symptoms. And the standard surgical technique, historically involved chelectomy and a rotational osteotomy of the metatarsal head. Next slide, please. So there's different ways of managing Freiberg disease. One is by interposition, which is just creating a false space between the articular surface, and something that's come into use more recently is the polyvinyl alcohol implants. Specifically speaking about the Cartiva implant, and it's used for usually first MTPJ arthritis, just to delay the procedure of chelectomy, and delay the requirement for a fusion or a replacement. The common revision procedure of a PVA implant, to the first metatarsal phalangeal joint fusion is not compromised as the insertion. And PVA usually leaves a good bone stock. You don't need to knit away at the bone. That's the good option of having the PVA implant, is that you have good bone stock if you want to ever want to do something else in the future. And the only real complications that you can get with a PVA implant is that it's either collapses, it wears over time, or it fractures. Now, there's never really been any studies into how long these implants last, but it's generally accepted that every 3 years, it should get moved or it should get replaced. Next slide, please. Yeah. So the case report we wanted to discuss was a 35-year-old gentleman who basically presented to our foot and ankle clinic. He's fit and well. He's a non-smoker. He's an active gentleman who runs daily or 6 days a week at least. And basically he presented with crepitus in his fourth MTPJ joint. And he's had a recent operation, to have the Cartiva implant inserted maybe 2 months ago. Yeah. And the majority of his symptoms were in the third walker of his gait. Next slide. So an examination, there was a heel scar for the dorsal aspect of the third toe. No signs of infection. The dorsal drawer test was negative, suggesting the joint wasn't stable. Was positive, suggesting the joint wasn't stable. He had a positive grinding test as well of the third MTB joint, producing painful clicking, which reproduced the symptoms. And, there was extensive stiffness in the joint in the form of reduced range of movement, and he was only able to lift his toe about 20 degrees from the ground. Active plankton flexion of the MTB joint failed at the pulp of the toe. And as some might be aware here, that leaves them with a floating toe deformity. Next slide, please. So we can just see the pre-op CT scans. You could see the destruction that the Freiberg disease can cause, and on the third metatarsal head for this gentleman, You could see some osteophyte formation, and you could see on the sagittal view the area where the Cortiva implant should insert into the metatarsal head. And this image here is characterized also by decreased joint space, which would suggest that the implant is failing or wearing off. And this shouldn't happen 2 months post-op. You know, we'd expect to see something like this 3 to 5 years post-op. So next slide, please. So we had a discussion with the patient. You know, we discussed the options. You know, he's only just had his operation recently, and we discussed about conservative options, which never worked for him. He's a gentleman, like we said, that was you know, he was very active and he wanted to get back on his feet as soon as possible. You know, the options of reinserting a PVA implant, you know, it will need revision every few years, as discussed. So basically we give the options of either having an osteochondral bone graft versus an excision arthroplasty of the proximal phalanx. Next slide, please. Obviously the proximal phalanx, you know, by itself, it has its own complications. So, you know, of excision arthroplasty in the form of having a floppy toe, diversion of the second and fourth toe, potential metatarsalgia. These were all things that were discussed with the patient, and then, you know, the patient understandably wasn't keen on being subjected to these complications. He didn't want to go through the risk because of his background, so he decided to go for the osteochondral graft instead. Next slide. So the technique itself, the incision, it was the dorsal incision was made over the old scar, no new fancy incisions, with a dorsal release of the joint and partial release of the collateral ligaments around the brace, the proximal phalanx. Once we got in there, there was bone-to-bone dorsal impingement of the bone. The PVA implant was fragmented, non-functioning and loose. Within the joint, the collapse of the articular surface measured about 5 millimeters to restore the tension of the collateral ligaments, which confirmed that another PVA implant is not technically possible if the aim is to restore function of the joint. About 20% of the dorsal articular surface of the proximal phalanx showed, you know, advanced signs of osteoarthritis. Next slide, please. And so, yeah, we basically removed the implant. It measured at 6 millimeters. Afterwards, you know, we over drilled the 8 millimeters to refresh the edges, and you know, we harvested a bone graft from the lateral condyle of the ipsilateral femur. The graft was inserted into the metatarsal head and sucked about 30 degrees of dorsiflexion of the MTB joint, and articular congruency is restored. With only dorsal partial release of the collateral ligaments. You know, we did the dorsal twist off screw, was inserted to maintain the graft position and prevent further collapse. After that, you know, we just proceeded to do the dorsal chelectomy of the proximal phalanx, and then the wound was closed in layers. Next slide, please. So that's the operative images you can see from me there, that we just went over the old incision, released all the collateral ligaments. You know, you can visualize the implant there if you zoom into the photo. And then, you know, when you move over to B, you can see after measuring it that we've over drilled to refresh the edges in the proximal phalanx. And then we just removed the implant and inserted the osteochondral bone graft. And with a 30 degrees of dorsiflexion, we did the knockoff screw just to hold everything in place. Next slide, please. Post-op, the patient was lightweight but was tolerated. We did a wound review in 2 weeks, make sure everything was okay. He wasn't given any VTE. The patient, you know, we told him he can mobilize with a moon boot, and he carried on for about 6 weeks. and we recommended that no running for, for at least a period of 4 months. Next slide, please. So the final scheduled review, the standard post-op review was meant to be 1 year post-op, but we've seen the patient another couple of years later. But the examination of it showed that the can plantar flex and load the toe with no deformity compared to the other toes, and there was no impingement and dorsiflexion from the ground. Was around 30 degrees. The grinding test was negative, which he had previously, so there was a clear improvement in his symptoms. The patient was able to resume his sporting activities and was satisfied with the outcome of the procedure. Next slide, please. The only limitation was obviously that long distance running wasn't achieved at 1 year. It was achieved later on after 2 years. It was likely due to the residual stiffness of the joint. The stiffness of the joint is likely due to the contraction of the plantar plate, especially from scarrings from previous surgeries. Next slide, please. You can see the X-ray here, 1 year post-op. You can see in the third metatarsal head, he's got the dorsal screw in place there, just holding the osteochondral bone graft. You can also see that there is a widened joint space in the third metatarsophalangeal joint there, compared to the others, and there is some reactionary, osteophyte formation from the base of the distal phalanx, and the proximal phalanx as well from the gentleman's previous disease. But the main finding is here is that finding that the joint space, was fully preserved here. Next slide, please. So, just have a discussion about the management of Freiberg's disease in general. Whenever a patient is subjected to late stage treatment to relieve the pain, what you want to do is actually restore the metatarsal function and reestablish the correct distribution of the body weight. The procedures employed of the advanced disease include excision of the metatarsal head or the base of the proximal phalanx, shortening the metatarsal, intra-articular, extra-articular, dorsiflexion osteotomy of the metatarsal head, interposition arthroplasty with a biological silicon spacer, or osteochondral plug transplantation. And the last two are the options that we've treaded down, basically. So next slide. So the technique of the dorsal wedge osteotomy is the technique, that's more commonly used. It's got reproducible results, and there's been previous studies into it, with 12 patients and 40 months follow-up post-op, with metatarsal shortening, an average of 2.1 millimeters. They've scored pretty well on the patient-reported outcome measures. Showing 4 excellent and 7 good ratings, and 2 patients with poor suffering from transfer metatarsalalgia, as a result of excessive shortening. Next, please. Interposition arthroplasty with a silicon spacer, or like in our case, we used a Cartiva implant, but for the silicon spacer, it's been observed by Caccarillo et al., but had a failure rate of up to 12%. And the mean follow-up in their study was 37 months. And the operated metatarsal head often would not support mechanical forces directed on it. And these patients often complain of foreign body synovitis and transfer metatarsalgia. The use of osteochondral plug as a means of a primary intervention for late-stage Freiberg disease sometimes has been commonly used. Myotoma et al., they've examined 4 consecutive patients, all of them female, with a follow-up of 52 months, and they've shown that the results of the AO, FAS score improved from 70 to 97 points post-op. Next slide, please. So the Cartiva, it's a novel osteochondral defect repair implant with prosthetic, with the properties similar to that of a, cartilage, essentially. It's designed for treatment of osteoarthritis of the great toe, basically. That's what it was originally designed for. It's a polymer comprised of full of phenol alcohol, which is 40% that and 60% saline. So there's a lot of fluid in it. It's got high shock absorbing ability. It's got high wear resistance, wear particulate biocompatibility, and the properties which are necessary for suitability as a biomaterial intended to replace a damaged cartilage. The rationale for using the PVA implant was to provide interpositional arthroplasty for the second MTBJ to alleviate pain. Next slide, please. So there is a study also done by Bofa et al. Representing the largest case series to date with 13 patients, which was to assess the PVA implant and surgical correction of the lesser toe. And pathologies, not limited to, but it included Freiberg disease. And basically, the results, pre and post-operative measures were checked, and they showed a clear improvement on this. And the comparative study was carried out to compare the efficacy of Cartiva versus an osteotomy, the treatment of conditions of the second metatarsal head, which showed that the osteotomy had outperformed the Cartiva implants. And these patients, I remember from the study, were followed up by MRIs and post-operative X-rays, and the Freiberg, the patients who had the Cartiva implant, one of them subsequently failed and had a revision to wheel osteotomy at the mean of about 15 months post-operatively. Next slide, please. So to conclude, there's various surgical techniques that have been described for Freiberg's disease with varying degrees of successes, suggesting that the surgical, challenge in treating such cases are modification of bone grafting, allowed for restoring of the joint space and therefore provided better function. If such, an approach may only be best managed in a situation like ours, where the patient's lifestyle is to be put in consideration when discussing different treatment options. And the technique described above, is simple to perform. It's not very complex, and but more cases and longer follow-up are obviously required before it can be suggested as a valid alternative to treatment of Freiberg disease in patients with a failing PVA implant. The limitations of this report, were obviously that it was carried out by one surgeon, and we only had one patient for this study, and obviously we didn't follow him up long enough post-op to make the suggestion forward. But we published this paper in the American Journal of Foot and Ankle Surgery, and it's been peer-reviewed. And next slide, please. I think that was the conclusion of that. Yeah, and we've just got the references here. So yeah, no, very good. So thank you very much. I'll take any questions if anybody has any.
Thank you so much, Dr. Dafala. It was an
My name is Claudia Villani, and I am an Italian transdisciplinary cultural artist and designer. Since 2018, I have dedicated myself to the study and experimentation of transformative artistic practices in the field of fibromyalgia syndrome in collaboration with Dr. Sapio. In this pitch, in addition to reporting the theoretical and practical assumptions and the results of our study, I will cite some studies that have been published subsequently, but which have helped to support our starting hypothesis. Pharmacon, The Art That Cures, is a prospective observational study with which we tried to validate art as a tool, as a practice of integration with treatment, within the framework of a multimodal therapy of fibromyalgia syndrome in a self-care direction. It is based on neuroscientific and non-art therapeutic assumptions. The Sicily region, the Bucherella Fate Bene Fratelli Hospital, the AISF ODV Association, and 2 Palermo museums collaborated in the study. The study took place entirely online and involved 109 patients, 40 doctors, and 8 caregivers. In 3 arms of observation, a path through poetry, therapy, and narrative writing, 1 through humor therapy, and a more experimental arm based on neuroaesthetic studies, using museum works in an elaborate audio-video support to stimulate the aesthetic perception of the sublime. We referred to different disciplinary areas. The founding hypothesis of our study is that art as a transdisciplinary language in an appropriately structured context can be an effective catalyst for implementing transformative processes in a very short period of time, and which can induce a measurable improvement in the clinical, psychological, and somatic picture within a multimodal therapeutic asset. In the article, Complexity Theory Applied to the Interaction Between Culture and Health, Professor Grossi from the University of Turin clarifies how complexity theories have helped us to understand that acute diseases more often behave like complicated systems, while chronic diseases more often resemble complex systems. Professor Grossi has summarized in this diagram the difference between acute complicated illnesses, chronic diseases, complex. A complicated system contains a large number of parts, but it can be broken down into a set of simpler and independent subproblems. It can be studied from a disciplinary perspective according to a linear logic of cause and effect. A complex system, on the other hand, is composed of many interrelated parts that affect one another. It does not concern a single disciplinary area and works according to the retroactive circular logic of nonlinear systems. The consideration we started from was that a paradigm shift was needed to tackle a complex systemic disease. Transdisciplinarity is a procedural model. It can be considered an overcoming of interdisciplinarity. If the latter operates by breaking down the boundaries between disciplines, transdisciplinarity integrates them into a wholeness. The principle behind this assumption is that 1 + 1 does not equal 2, but at least 3. The extra is given by the value of the relationship between the parts. Van Bever, in a 2017 research, analyzes the term to clarify the difference between multi, inter, and transdisciplinarity in medicine and give a better definition of it in the healthcare sector. The term is increasingly used in healthcare research and has been identified as important for improving the effectiveness and efficiency of healthcare. However, it continues to be misused and poorly understood by both researchers and clinicians, which hinders its potential use. Van Bever concludes that transdisciplinarity in healthcare implies crossing disciplinary boundaries, sharing knowledge, expertise, and decision-making processes, a focus on real-world problems, and the inclusion of multiple stakeholders, including patients, their families, and their communities. It is therefore the most suitable procedure for implementing the psychosocial biomodel, which is the most functional in pain management. We based our study on the hypothesis of a traumatic origin of the disease, confirmed by much research in recent years, which shows that fibromyalgia patients have a higher percentage of trauma exposure compared to control patients, more traumatic experiences, emotional and physical, and more PTSD symptoms. The results suggest that future research should further explore the efficacy of trauma-focused therapy versus the cognitive behavioral psychotherapy that is currently the standard of these patients. We have considered the concept of trauma from a broader perspective, referring to the PNEI definition of trauma, which considers it as an intense but short-lived negative event, or milder but protracted, known as a pro-inflammatory stressors element, which can be of various kinds: work with the like, family arguments, both physical and mental trauma, even mild ones, lack of physical activity, nutrition, lifestyle. This state of chronic inflammation persists because the causes that caused it have not changed, generating a continuous energy loss in an attempt to maintain homeostasis. This is why we have referred to Ethan Russo's studies on endocannabinoid deficiency in fibromyalgia. These studies, left aside for a long time, are now also supported by an emerging literature, as already cited by Dr. Sabio. The 2014 systematic review also studied clinical interventions that improve the ECS. It emerged that in addition to drugs, clinical interventions, defined as complementary and alternative medicine, can also regulate the ECS system, endocannabinoid system, massage manipulation, acupuncture, food supplements and herbal medicines, sports, activity, and lifestyle modification. In 2019, the World Health Organization report on the function of the arts in health was published. The largest review ever carried out references 3,000 studies from the last 20 years. It was an important confirmation that the arts are useful tools for promoting health and preventing diseases, as well as improving the quality of life of patients and supporting the health service in the difficult management of chronic illness. The WHO, in fact, urges us to increasingly increase the use of art in treatment pathways and to implement health reforms that focus on basic care, focused on the development of individual resources, empowerment, considering the sick person not a simple passive recipient of healthcare services, but as the first and fundamental operator of care work towards his or her own health. Given these premises, it seems essential to start with the identification of the trauma or stressor and the reorganization of the dysfunctional adaptive patterns, which, from an epigenetic perspective, can also influence the biological aspect, because without this transformation, even effective therapies, such as medical cannabis, could in the long run become useless, if not harmful. We structured the 3 transformative pathways, not aimed at restoring homeostasis, but for a different functional rebalancing through a hormetic procedure that could act as reactivators of the trauma through a disturbing stimulus. In a second step, we encourage the creation of a new, broader, and more functional psychic scheme through narrative medicine and the use of therapeutic metaphor. As Tedeschi, R.J. and Kowloon in 2004 have shown, the paradox of trauma is that it can both damage us and expand ourselves. We have also included poetry, therapy, and humor in the meaning of art because they share the same matrix of paradoxical communication as defined by Bateson for the formulation of the double bond theory. There is an ambiguous and unambiguous communication capable of confronting a perceptive bifurcation, which, generating disorientation, opens up to new knowledge. We found important confirmation of our hypothesis on the hormetic process in Brouwer Harris 2020 study, in which the authors explain a new construct that pivotal mental states, PIMS, defined as a hyperplastic state that promotes rapid and deep learning capable of mediating psychological transformation. The authors highlight how chronic stress and neurotic traits are precursors of pivotal mental state, while acute stress can be a trigger. In continuity with this definition, PIMS Kirkos 2022 study on transformative experiences has been of great support in contextualizing our definition of transformative artistic experiences. According to the authors, the concept of transformative experience has been widely explored by different disciplines, from philosophy to neurobiology, clinical and experimental psychology, and many others in different fields. This has generated heterogeneous models to explain this phenomenon. The authors have attempted to provide an integrated theoretical framework of TE and a preliminarily interdisciplinary operational definition. Most researchers agree that TE can be conceived as phenomena capable of generating lasting, irreversible, and pervasive consequences on the beliefs, perceptions, identities, and values of individuals. The stimuli that enable transformative change are still open questions which need to be studied separately. TE can profoundly change people's values, priorities, and self-concept, thus transforming an individual's identity with an irreversible cognitive change, leading to new frames of reference for seeing oneself and others differently. Recently, interest in transformative and self-transcendent experiences, STE, has also grown in the field of human-computer interaction and experience design. In our research, the artistic transformative workshops experienced, taken as a whole, resulted in a statistically significant quantitative improvement on all parameters explored by administering of 6 sets of tests. The first arm of the study resulted in improvement in sleep quality, general health, self-efficacy in the dimension related to emotional maturity, context analysis, and action finalization, perceived well-being, attention, and self-esteem. The second arm of the study resulted in an improvement in sleep quality and self-efficacy in the relational fluency dimension. The third arm of the study resulted in an improvement in self-esteem and perceived well-being. The most interesting qualitative results reported by the patients were that they saw deep emotional content emerge even in a single meeting, as in years of psychotherapy, probably also thanks to the remote activity which guaranteed a sort of protection. Sharing an artistic experience also made it possible to build an intimate environment of total listening and total openness in a very short time. Many patients reported after a week having greater clarity about their situation, experiencing a greater autonomy and decision-making capacity for their lives, and an increase in empowerment. Regarding the use of poetic metaphor as a diagnostic and therapeutic tool, almost all patients found a complete and satisfactory identification with the metaphorical synthesis, and many tried to use it with a referring doctor. The conclusions that have emerged lead us to think that it would be useful to pursue certain lines of research that emerged from the study. A study on the endocannabinoid system to identify the biological mechanism triggered by art, starting again from Ethan Russo's studies. Deepening the relationship between the biological and physical aspects highlighted by studies of mitochondrial psychobiology. Deepening the effects of immersive, artistic, transformative experiences on the ECS with the use of new technologies and AI. Studying the effects of transformative art practices on pain, starting with the results of the 2021 study not yet published. Explore the relationship between EMDR and audio-video work for trauma emergence. Experimenting the transdisciplinary method involving specialists from other non-medical disciplines to investigate the new hypothesis of the etiopathogenesis of a fibromyalgical syndrome and to improve the integrated diagnostic and therapeutic approach. We think that these efforts in a systemic and transdisciplinary direction could open up useful insights into both the etiopathogenesis and more effective diagnostic and therapeutic path of fibromyalgia syndrome. Thank you very much for having followed us and enjoy working on your conference.
In publications and in registries, we can see that more than 30% it's malalignment. And in literature about navigation, we know a lot, and a lot of publications told us about that it's a better navigation in total knee arthroplasty and better results. And we appreciate our results, and from 2008 to 2018, 979 navigated TKA in 786 patients. And most of them was female. And we divided in groups. So valgus group, and the most biggest group was varus from 0 to 10. And next group was varus from 10 to 15. And 53 patients in group varus from 15 to 20. And 46 patients more than 20 degrees varus. And what does mean is difficult knee? In the Baldini report, for example, we can appreciate and see that total knee arthroplasty, its varus deformity is the most difficult, and a lot of articles about it after osteotomy and neglected patellar dislocation, knee recurvatum, and severe valgus. But we decided to appreciate especially varus deformity, which is more often. And when we analyzed all our navigated cards and navigated files, we found a lot of patients with severe varus, and we found that then we have more varus, and the flexure contracture became more severe in these patients. And next, we divided patients in groups, and very often groups was flexion with varus. It's usual when we see varus deformity and flexion contracture, and it's usual. But very interesting situation when we have flexion varus and hyperextension varus. Flexion valgus and hyperextension varus, because it's a difficult situation in bone defects, and it responds to another bone cuts when we analyzed all our files, navigated files, we perform this formula for bone soft tissue release, and A, pre-op deformation, B, distal femur cut correction, proximal tibia cut correction, deformation angle after resection, and release in degrees. And when we see these groups and evaluate all these groups, and we can find that then we have more varus deformity. We need, of course, more soft tissue release, and it's almost something 9 degrees. And it's very important for understanding, but we cannot compare it with normal total knee arthroplasty without navigation, is because it's very difficult to find real angles in which was cut performed. And our results, we evaluate these patients, and average all operations were done with average residual deformation 1 degree from 0 to 3. It's normal for navigation. It's very good because 1 degree is real deformation. when can be loose in patient. And mean follow-up was 91 months. And patients were 67% of patients were available, 23% of patients were unavailable. For us, who died and who was unavailable and non-reachable. And we revised 10%, and the reason for revision very often was loosening, next was infection, and next instability. That's really, that's in the registries we can make. And when we appreciate Oxford score in these patients after 12 months after operation, we see that in, for example, group over 20 degrees, we can meet not so real good Oxford knee scale. It's a little bit worse than in previous groups. Of course, severe deformation, but I told previously that we correct all deformations, but despite complete correction, we have not so good scales. For example, pulse scale in varus, it's excellent pain, symptoms, quality of life, it's very good. When varus is more great, we see already that quality of life and daily activity, it's a little bit less, and the scales from 15 to 20 degrees and more than 20 degrees, you see the same situation. Instead of, despite of ideal positioning, functional scales are worse in severe virus groups. But it's ideal line, it's ideal alignment, and for example, in several cases, female 78 years old, and you can see upper part of the slide, severe varus, 20 degrees inflection. And the left side, severe varus and hyperextension, mean that anterior and distal part of condyle was absent in this patient. And the navigation after surgery here, and X-rays, and this 3 years post-op and before surgery. Next, 78 years old, severe valgus, and this with hyperextension. It's a real situation. After surgery, navigation cut, and 10 years after TKA, and severe cases. For example, for us, severe cases, we saw that it's trauma and osteotomy, hyperextension deformity, and I show cases when the navigation was very useful. And for example, severe varus, you saw, and here is difficult total knee arthroplasty after extraarticular deformity. And the next, oh, sorry. And of course, post-traumatic arthritis is a challenge for surgeons. Problem must be identified before surgery. Of course, special imaging and choose right implant, but we need to use, for example, navigation system. For us, it's very comfortable, and we can always decide what we can do. And for example, total knee arthroplasty after compensated varus. And you see here 30 degrees, and LDFR and PTR, it's almost defects. Sometimes it can be more than 4 centimeters. And after valgus deformity, bony defects, of course, you need lateral extensive release, recurvatum usually, and patellar tracking. And example, navigated case, you can see here valgus deformity, hyperextension. It's very difficult situation. And when we operate with navigation system, we can perform proper cut. We can calculate each millimeter. In this condition, especially when we have hyperextension, we can very carefully be, especially for femur cut, and we do minimal cut femur, for example, 5 millimeters, and severe coronal deformity more than 20 degrees. It's a very good review. When also spoke about complications and sorry. Another button. And they also spoke about complications and spoke about severe deformities and difficulties. And high TBI osteotomy. It's a challenge for surgery because if you have only short X-rays, you cannot appreciate deformities, real deformities. And the navigation system help you to see it in surgery, during surgery. And if you prepared with long-standing X-rays and if you evaluate everything, you can do it. And in this condition, only you see, maybe it's simple, only 4 degrees hyperextension and only varus 11 degrees. But it was already osteotomy in childhood, and because of it, we have a crazy MPTA, LDFA, and we need to do another cuts. And only navigation system can you allow to do it. And when we do these cuts, and almost good tibia, but you need resect 11 millimeters from lateral part. And in this condition, we can do proper cut and restore joint line. And you see X-rays, you can use only short stem because you cannot do. And you see only 1 year after, you can go without pain and a good range of motion. And post-osteotomy deformity, it's a good review too, and really it's situation for good planning. And recurvatum, it's a problem definition. Normal active random motion, you know, is from 0 to 120. Normal passive random motion -10 to 150, and hyperextension mild 1 to 5, moderate 6 to 10, severe more than 10. But sometimes we see normal people more than 10 degrees hyperextension. And the compensation, if the compensating hyperextension more than 15 degrees, and usually we can meet it in polio patients. And of course, it's a challenge for surgery. And in this condition, we have great extension gap and short flexion gap, and we need to perform correction bone cuts. And it's maybe it's simple if we have no real polio patient with a real hyperextension. For example, male 48 years old, polio patient, bilateral decompensated hyperextension, gain recurvatum, range of motion 35 -35 to 129. Muscle strength 1 to 2 points. And of course, it's not so good muscles. And arthritis and pain. What we can do in this condition, of course, it's we need to do surgery. But in this condition, when we perform bone cuts, we need to think about his future, because when he all his life can step only with hyperextension, he will not be possible to go. We will be able not be able to go in straight alignment 0-0, for example, because he cannot lock his knee. And this condition, one solution can be, for example, hinge prosthesis with hyperextension, small hyperextension, and in this condition he will lock his knee. And navigated right knee before and after. And we shortening this hyperextension and 7 days post-op. Next, 7 days post-op, and navigated after 6 months left TKA, the same condition, and left TKA was 38 hyperextension degrees, and we leave here 11 and small valgus, and 1 year from right and 6 months. Sorry, it's a little bit. I'm sorry. And here's a match 2023, and this patient be able he is satisfied. It's already 2 years and a half after operations. And last case, it's very difficult. Young man, difficult trauma, it's motor trauma in 2011, polytrauma, right humeral amputation, open distal femur fracture, external fixation, then after it, ORIF after, and metal removal in 2012 with these X-rays. And you can see here non-union of distal part of lateral condyle and fixed patella. And 2017, limping, range of motion from 15 to 40 degrees, multiply scars and always sensates, loss of function. And of course, without right humerus. And if we analyze deformation, we see LDFA 115, MPT 82, it's almost normal tibia, intramedullary angle 15 degrees, and in this condition, it's only situation for navigation system. And sorry. Sorry. And you see situation in navigation system before TKA. Varus 13 degrees, flexion 6 degrees, and it's not so alleged to be a serious situation, but trauma, it's almost individual. And when we plan it to do with navigation system, when we have a condyle, for example, especially femoral condyle fractures, we cannot appreciate where condyle alignment can be and where points for navigation. And usually we appreciate it with navigated CT scans and navigation, and we put this point almost individually. And you see proper cuts in the upper, in the lower part of slides, and really it's good of alignment after surgery. And you see alignment diagram before surgery, and you see after surgery. It's almost straight line. And this surgery, you see, and after surgery, And after 6 months post-op, its range of motion 0 from to 85. And he was glad with this result, but I cannot show video. And August 2022, 4 years and 6 months post-op. Try to put video here. I'm sorry, but it was lost in files. But this man now is have a job and work in a good time. He is satisfied very much with this. And in discussion, and proper alignment, it's discussable because a lot of theory now about alignment, the kinematic, anatomical, and else and else. But some authors relate, for example, Jeffrey Morris and another authors that when maquette line was aberrant more than 3 degrees, medially or laterally, the incidence of loosening was 24 after 8 years. It's a very great, quantity of patients. And the controversion, for example, Daniel Berry, Parat, and Trasdale, Pagnano, they evaluate almost 4,000 patients with cemented primary TKA, 14 years follow-up. And they reported that 84.6 survival in the group aligned within 3 degrees from the mechanical axis. And the 106 knees were regarded as outliers, deviation more than 3. And survival was more, 87%. It was suggested that restoring a straight axis in TKA might aim the wrong target. But I think maybe after 10 years, maybe 20 years, we can see it in literature else. But now it's only beginning, maybe 2, 3, 5 years of another alignments. And now we can have a support in registries. For example, Australian National Registry show after 10-year navigated replacement that the patient's age less revisions. 10 hundreds, it's already more. And of course, it's very good. In conclusion, I can tell that navigation system in complex cases is the best because flexion extension gaps alignment, correction accuracy in 1 millimeter and 1 degree helps to control rotation alignment. In 10 years, survival is better with navigated. In our case, it's 90% than convenient TKA because in literature we can met from 74 to 88% survival. And next, we hope that the robotic system will help us to do TKA in severe deformities because now it's impossible with it. Thank you very much.
Thank you so much, Dr. Valeria. It was an excellent presentation. Thank you.
Thank you for your invitation.
Next, I would like to welcome Dr. Henry Liabak from the Institute of Traumatology and Orthopedics by National Academy of Medical Science of Ukraine on the title of Evans Musculoskeletal Osteotomy in the treatment of flexible flat foot in children. Hello, Dr. Henry. Hello, Dr. Henry, are you there? Moving on to the next presentation, it will be an e-poster presentation from James Butler from NYU Langone Health, USA, on the title of The Role of Patient-Specific Instrumentation for Total Ankle Arthroplasty, a Systemic Review.
name's George Slade. I'm an orthopaedic registrar from England. Thank you for having me, firstly, I'd like to say. And then, so today I'm going to talk to you about what is the posterior condylar offset ratio for both the medial and lateral femoral condyles. So first thing I'd like to say is I have no conflicts of interest to declare. So what is the posterior condylar offset and what's the ratio? So the posterior condylar offset is a measure of condylar anatomy whose importance in the context of the total knee arthroplasty has been widely debated. The PCO, which I'll refer to throughout this presentation, was first defined by Bellmans in 2002, and it's based on lateral radiographs as the measurement of the maximal thickness of the posterior condyle projected posteriorly to the tangent of the posterior cortex of the femoral shaft, as shown on the picture on the right-hand side. Now, in order to mitigate magnification error, further studies showed that they improved the concept by proposing a posterior condylar offset ratio. Now, what is this ratio? Well, the ratio is defined as the maximal thickness of the posterior condyle projecting posteriorly to a straight line drawn as the extension of the posterior femoral shaft cortex divided by the maximal thickness of the posterior condyle projecting posteriorly on the lateral radiograph. Now, there's a schematic on the right-hand side which shows the measurement of the posterior condylar offset before and after a total knee replacement. So there are many ways of measuring the PCO and PCOR. Now, traditionally, a lateral radiograph was used. Nevertheless, evidence suggests it's prone to error. Now, what are the current limitations of current research? Well, there's many ways of measuring the PCO and PCOR. Firstly, in order to achieve a true lateral radiograph, a degree of femoral rotation is required to achieve an overlap of the condyles. Now, as femoral condyles are asymmetrical, this introduces a degree of inaccuracy. And multiple studies have demonstrated that when compared to 3D imaging, both CT and MRI values obtained from plain radiographs do not correspond to 3D measurements. Also, plain radiographs fail to take into account cartilage thickness, which can vary significantly between the condyles. Now, in order to mitigate some of the issues mentioned previously, 3D imaging method is required. Both MRI and CT have been trialled to look at the PCO and PCOR. And some people have used CT scans to analyze the variability of the geometry of the femoral condyles. And one person, so Canotti, in 2012, first pioneered the use of MRI when exploring the correlation between PCO and sagittal slope of the tibial plateau. Now, since then, multiple different protocols have been trialled, with very little data concerning the measuring techniques, reproducibility, and reliability. Now, this leads on to our study. So what were the primary aims of our study? Well, our study, firstly, our first aim was to create a reproducible and reliable MRI protocol for the posterior condylar offset ratio measurements based on a sample of non-pathological knees. And the second aim was to identify any morphological differences between the condyles. And I'll tell you a bit more about that now and how we went about doing that. So what were our methods? Well, it's a team of 5 reviewers, including myself, and an orthopedic consultant and specialist MSK radiologists collaborated together in order to create 2 novel methods of measuring the PCOR. Now, both methods use the T1 weighted image of the knee joint in both the axial and the sagittal plane. Now, the main difference was the way the axis of the measurements were set. Now, one method used the posterior condylar axis, known as the PCA, and I will refer to that throughout the rest of the presentation as the posterior condylar axis, which is the PCA, and the other, the transepicondylar axis, known as T for short. So, what do we do for our MRI protocol in terms of the PCA method, so the posterior condylar axis? Well, firstly, using an axial view, the peak of the posterior femoral condyles was identified, and a straight line was plotted passing along the most posterior aspect of the cartilage of both condyles, shown in the image on the screen for you there. Now, another line parallel to this was drawn at the posterior-most aspect of the intercondylar fossa. Now, this set out the axis of further measurements. Okay, I hope you're still following me thus far. So next, on a sagittal plane, an image most alike to a lateral radiograph was identified. It's shown on image B on the screen in front of you. Straight lines were then drawn to outline the femoral cortex and help identify the point at which the femoral shaft increased in diameter and flares out into condyles. This was then used to transpose the previously drawn lines onto the corresponding level in an axial view and obtain a measurement of the width of the femoral shaft. Now, in order to measure the medial femoral condyle width, an additional line, parallel to 2 previously mentioned just a moment ago, was drawn in an axial view at the posterior-most aspect of the medial femoral cartilage. Now, the width was then measured using a perpendicular. Using this method between each of us when we were calculating and looking at the MRI scans was actually relatively easy to reproduce and follow those steps. Now, how about our other MRI protocol, so the transepicondylar axis? Well, similarly to the PCA method, the T method was also based off an axial view of the peak of the posterior femoral condyles. Next, 2 parallel lines were plotted, one from the lateral ridge to the medial sulcus, and another at the most posterior part of the trochlear groove. Using a sagittal view, the image most alike to a lateral radiograph was identified, shown on B there again. The level at which the femoral shaft flares out into femoral condyles was found. This level was then used to transpose the previously drawn lines into the axial view and obtain a measurement of the width of the femoral shaft. Once complete, these lines were set and a level at which the posterior femoral condyles are most posterior in the axial view was found again. A line was plotted along the most posterior aspect of the medial and lateral posterior femoral condyles, which allowed for a measurement of the peak of each condyle. This was then used alongside the measurement of the femoral shaft in order to calculate the PCOR based off the method first proposed by Journal in 2012. And all of my references I'll include at the very end of the presentation for anyone that wishes to have a look through those. So as you can see, this is figure 2 of an MRI scan showing our T method that we proposed and to calculate the posterior condylar offset ratio. So what about our data? Well, and our study. So it was a retrospective analysis of knee MRI imaging data collected in one centre in the UK in Bristol. Now we used a system called PACS. We used to search MRI scans in June 2022 in order to identify all scans that had been reported as having no internal derangement, okay? So they were non-pathological knees, as I previously said in our protocol. So no time limits on the date when the scan was performed were imposed, and the project was approved by the Institution Review Board as a clinical effectiveness project. So who was eligible for our study? Well, using the previously mentioned methods, there was 151 results. And so then what did we do? So one researcher in our team carried out a detailed content analysis of all radiological reports and excluded those with pathology. Additionally, all patients under the age of 18 at the date of the scan were excluded. If the patient had multiple scans of the same extremity, the oldest non-pathological scan was included. In the event that both knees were investigated on the same occasion, only the knee, which was imaged first, was included. And this left us with 103 results. So what did we do with these 103 scans? Well, we used a standardized data collection spreadsheet, which was used by one independent reviewer. So we collated data such as hospital ID, date of investigation, age at time of investigation, gender, and laterality. We used Insignia software to obtain the measurements, and a total of 4 different MRI scanners were used. The medial and lateral PCO length and femoral shaft diameter was measured using one of the 2 previously described protocols by at least one reviewer. And in order to establish inter-rater reliability, a random sample of 10 patients was selected and reviewed independently by 4 reviewers. This sample was also analysed by a blinded reviewer, which in this case was one of our team members, Esther, on 2 separate occasions, 2 weeks apart, to investigate intra-rater reliability. Once this was established, one reviewer analysed the remainder of the scans. So, what did our results show us? Well, out of the 103 scans of healthy MRI scans, 57 were male, 46 were female, and these were analysed. Average age of the patients was 24 at the date of the scan, and laterality was roughly matched, with 57 scans involving the right knee and 46 the left. How about intra-rater reliability and our results? So using the T method, Esther shows significant correlation between the 2 measurements taken on separate occasions in both the medial PCOR method, with a Pearson correlation of 0.747 and a significant p-value of 0.013, and a lateral posterior condylar offset ratio with a Pearson correlation of 0.761 and a p-value of 0.011, as shown in the table in front of you. And when using the PCA method, there was a significant correlation with the lateral posterior condylar offset ratio, but not with the medial posterior condylar offset ratio, as shown in the table in front of you. Now, how about inter-rater reliability? Well, a large range of degree of correlation and significance was observed between the 4 independent reviewers using both methods. On average, using the T method, a greater number of significant correlations between reviewers were achieved. and a total of 2 significant correlations in both the medial posterior condylar offset ratio and lateral posterior condylar offset ratio. Now, the range of Pearson correlation coefficients was smaller using the T method, and the highest correlation achieved was greater than the PCA method for both the lateral posterior condylar offset ratio and medial posterior condylar offset ratio, 0.71 and 0.943 respectively. Now, the lowest value for correlation was observed using the PCA method for the medial posterior condylar offset ratio and lateral posterior condylar offset ratio, which was a 0.098 and 0.221 respectively, as you can see in the table in front of you. So how about the morphology of the condyles, which was our second aim of the study? So based on an analysis of 103 knees, MRI scans, the mean medial posterior condylar offset ratio was 0.472 and 0.477 based on the PCA and T method protocol respectively. Now, the lateral posterior condylar offset ratio was 0.473 based on the PCA protocol and 0.455 based on the T protocol. Now, based on Levine's test for equality, equal variance was assumed. And when calculating the lateral posterior condylar offset ratio, there is a significant difference between the PCA and T protocol, with a mean difference of 0.0177 and a p-value of 0.011, but no significant difference when calculating the medial posterior condylar offset ratio, with a p-value of 0.423. So, this is a figure which shows the differences in the posterior condylar offset ratio between genders using both protocols, okay, using both the PCA and the T method. Now, when using the PCA method, when the mean medial posterior condylar offset ratio and the lateral posterior condylar offset ratio were compared, there was no significant difference between the two condyles. They had a mean difference of minus 0.00122 and a p-value of 0.862. Now, similarly to this, there was no difference between the condyles was noted using the T method as well, with a p-value of 0.539. Now, in both cases, equal variance was assumed based on Levine's test for equality as well. And unfortunately, there was no significant difference was observed between the medial posterior condylar offset ratio and the lateral posterior condylar offset ratio of males and females using the protocol described previously. Now, what were our key findings of our study? So I've explained the results and the method to you previously, but what were our key findings? So when calculating the PCOR, the T method has a good intra-rater reliability. The T protocol shows a higher degree of inter-rater reliability than the PCO protocol, yet consensus was not achieved among all reviewers using either method. Now, interestingly, there is a significant difference between protocols when calculating the lateral posterior condylar offset ratio, but not the medial posterior condylar offset ratio. Now, no significant difference between the medial and lateral condyles was observed using either protocol, and no differences between genders was identified. So how does this compare to previous work? Well, there are various different MRI protocols have been trialed with very little data concerning their reliability presented. Valetti in 2014 and 15 proposed a method based on the surgical transcondylar axis, utilizing this to represent the posterior femoral cortex tangent line and propagating it medially and laterally to the medial and lateral condyle respectively. Zanotti in 2012 further improved this technique by using a circle to help identify the greatest dimensions of the condyles, limiting errors inherent to selections of the slice. And lastly, Servian in 2007 proposed an alternative method which relied on measurements based on the surgical epicondylar axis in an axial plane and the tangent of the cartilage of the posterior condyles. Now, even though the use of MRI imaging helps mitigate some of the errors associated with the use of radiographs, it also poses certain drawbacks. Even small variations in sagittal MRI plane orientation, for example, due to the femoral rotation, can lead to systemic error of the PCO measurement. And when looking at the morphological differences between condyles, more data is available. So some further studies showed that there was no differences in PCOR in terms of sex differences. On the other hand, other people found significant anthropometric differences between sexes. In an osteological study in 2015, found that there was significant differences exist between the medial and lateral posterior condylar offset, but not between genders. So, what are the implications of the findings in this study for future research? Well, this study shows that it's difficult to find a reproducible and reliable protocol to measure the posterior condylar offset ratio. The restoration of posterior condylar offset is potentially a relevant factor in improving knee kinematics post-total knee arthroplasty, such as range of movement and patient-reported outcome measures. Hence, it's important to have a reliable way of measuring the posterior condylar offset. Now, 3D modeling could potentially help eliminate some of the issues encountered with our methodology. For example, Wang in 2014 used the Rhinoceros software, and another research used Mimic software. Nevertheless, this is often time-consuming and expensive. So what were the strengths and limitations of our study? Well, there are many advantages to the study, and to our knowledge, it is the first of its kind that focuses solely on validating a technique of measuring PCOR. It was of advantage that data from multiple blinded researchers was used in order to evaluate inter-rater reliability. Now, both methods proposed are also simple, time-efficient, and cost-effective. However, a limitation of this study was that the intra-rater reliability was established only between one reviewer. Also, only a small group of scans was analysed for reliability. And lastly, another limitation is the study only establishes the reliability of the measurement technique, but not its validity. So what are the conclusions from this study? Well, it's difficult to construct a reliable and replicable method of measuring PCOR, but the T method could potentially be a more reliable option for measuring PCOR. And when it comes to the morphology of condyles, gender and laterality does not seem to be a relevant factor. That's the end of my presentation. I hope you found that of value. Thank you very much for having me, and apologies I can't be there in person. I've included my email at the bottom of this presentation in case anyone has any questions about our study or wants to chat about any future opportunities or get involved in any research. So feel free to email me using the email below. And then this is a slide of all of the references that I used. So I will end that there. Thank you very much.